Right. Guys, is everyone here? Shall we turn on some cameras? Yep. Image is here. Tarinder is here. Good. Guys, who else is here? Turn on your cameras. Turn on your cameras. So today, there's a little bit of a problem. No electricity since the morning. So I've set up this, those rechargeable lights. So I set up one of those. And guys, if there is any, if suddenly, right, this is all running on battery, right? Everything's running on battery. If the connection goes, right, just stay in the class. I will switch and I will quickly come back. Okay. Don't leave the class. Okay. Right. If there are any connection related issues, Sharud is here, the co-host, just drop her a message. Right. And, any connection, any logging in to the meeting, anything, just drop a message on WhatsApp to one of the admins. Right. Okay. Right. Okay. So let's start today's class. Right. Thalassemia. Now, guys, everyone can hear me? All good? Give me a thumbs up. Yeah. Okay. Excellent. Okay. So thalassemia. Has anyone here seen a thalassemia patient? Do you all know what do you all know when you all hear the term thalassemia? Anything at all? What do you all know about thalassemia? Right, come on, let's stop. Unmute and say anything you all know about thalassemia. Okay. I'm going to ask one by one. So today we have so eight persons in the class now. Okay. Right. Who is here? Himesh. Anything about thalassemia?
Autosomal recessive condition.
Excellent. Okay. Autosomal recessive condition. Right. What do you mean by autosomal recessive? What is autosomal recessive?
Mother and father is asymptomatic, but each generation can have.
Right. So basically, the genetic defect must be there in both the parents, right? Both the parents for the child to get it, right? We'll do the cross diagrams and all of that. Okay. What is thalassemia, guys? Basically, this is now as your note says, right? You all can read your the definition in your note: a heterogeneous group of autosomal related inherited disorders, right? Big fancy words. Basically, right? There is a problem in hemoglobin. There is a problem in our hemoglobin, right? That is what thalassemia is, right? Specifically, guys, the synthesis of one or more, you all know hemoglobin is made of what? Heme, right? Okay, that's pen. Okay, start off this. You can see heme, right? Heme plus globin, right? This is our hemoglobin, no? Right? Heme plus globin. So this heme comes from the iron forms. We'll talk about those today as well. And globin is our protein, right? Right? Now, what is going to happen here in thalassemia, guys? Mainly, we are going to focus on this globin chain. There is some problem with relation to this globin chain, right? Globin chain. Now, so if we look at, we'll start off with the basic, right? We'll start off with the basic. If we look at the structure of hemoglobin, guys, it's what you call a tetramer, right? So basically, if I draw a hemoglobin molecule, right? So there are four globin chains, and in the center of each, we have the heme ion. So this is one hemoglobin molecule, right? So we have the heme group in the middle, this black one, and it is, there are four globin chains. These four globin chains, guys, right? There are two of each type. Now, what do I mean by that? What are these types? Let's take a look at these types. If we look at the types of globin chain, guys, mainly there are four types, right? There is an alpha globin chain, right? I will draw that in blue, right? Something like that, right? Alpha. Then we have a beta, right? Beta, something like that, right? And then we also have delta and gamma. This is the gamma, right? And let's say delta, right? Delta, right? These are the main ones. There are other types, guys. There is a zeta, there is a epsilon, right? Not necessary for us. Those are embryonic ones. Not really necessary for our discussion on thalassemia, right? These four we need to know. Right. Then the next thing, these combinations, the combinations of these globin chains will help us produce different forms of hemoglobin. What do I mean by that, guys? For example, now we said there are four, right? 4 globin chains per molecule. Usually what happens is, guys, they are found in combination. So now if I draw it like this, what does this hemoglobin molecule has? It has 2 beta chains and 2 alpha chains, right? The red and the blue, right? 2 beta and 2 alpha. That is one type of hemoglobin. Then you can have 2 alpha and 2 gamma. That's another different type. Like that, different combinations of these globin proteins will give rise to different forms of hemoglobin. That's the next concept I want you all to understand. We'll go into depth, and don't worry. Right. So if you all understand that, the third point we want to talk about is these different forms of hemoglobin, guys. They are found at different stages in our life. To be more specific, within the first year, from conception up to the first year, the forms of hemoglobin, they keep changing, right? So you all can draw something like this, right? Let's draw a small graph sort of thing, right? And we'll put somewhere here, let's say this is conception, right? Day zero, right? Conception, right? Conception, somewhere here. And then around here is 9 months. This is 9 months and you are born, right? You're born here. So this is birth, right? Birth. Okay. And then let's say somewhere here around 6 months of life, right? This is now your little baby, right? 6 months. And then here 1 year, 1 year. Okay. Right. So this is just a basic diagram. Okay. Just for us to understand. Here, let's say somewhere here, you all can put, let's say about 3 months of intrauterine life, 3 months intrauterine. Huh? This is up to here is intrauterine life, right? Okay. So let's say 3 months. Okay. What are we going to see, guys? What we are going to see is like this. Firstly, from the time of conception up to about 3 to 4 months intrauterine, right? We are going to see one type, right? One type of hemoglobin. This is, guys, called HbE, right? Hemoglobin E, right? Okay. This HbE, guys, again, right? There are multiple different subtypes, right? From the zeta and the epsilon, right? We don't need to know there's Goa type 1, Portland type 1, Portland type 2, right? Not necessary, right? So this hemoglobin E, by about 3 to 4 months, it usually disappears, right? While it's disappearing, right? At around the same time, at around 3 to 4 months, there is another guy coming up, right? There's another different type of hemoglobin, guys. This guy starts rising and he persists up to about, after birth, up to about 6 to 7, 8, 9 months, he persists, right? Around 6 months, he's dropping really low. And by around 8 months, he's gone. He's disappeared, right? This is what, guys, this is our HbF. This is what we call fetal hemoglobin. Now, though it's called fetal, it is persisting for the first 6 months. It's there. Okay. Just don't mix up the names, right? This is HbF. This HbF, guys, to be more specific, it is made up of 2 alpha chains together with 2 gamma chains, 2 alpha and 2 gamma globin chains, right? Okay. Right. So what is happening? This guy is coming down towards this 6 months after birth. He's coming down. So there should be another form of hemoglobin coming to take over its function, right? Exactly that. There is another form of hemoglobin, guys, right? Somewhere here, this guy starts rising, right? What is this guy? He is called HbA, right? Hemoglobin A. This is the adult form, hemoglobin adult, right? So hemoglobin adult, somewhere around the 5th to the 6th month, our body starts producing HbA. Here, guys, there are actually 2 forms, right? HbA1 and HbA2. Right? HbA1 and A2. Guys, just before we go any further, are there any first to third years here? Any first to third years? No? Right. So I'm assuming there are no first to third years, huh? Dilmi Tilakaratna. Which year are you in? 5th year. Okay. Which university?
Dalian Medical University.
Right. Excellent. Okay. So no first to third years, huh? No first to third years. Okay. Right. So here, guys, HbA1 and HbA2. Right? So I'm going to ask a little bit more advanced questions, huh? As we go along. Right. So HbA1, HbA2 in adult humans, what is the most common form out of these two? Come on. A1 or A2?
A1.
A1. Around 90, we say 97 to 98% is our A1, right? A2 is about only 2 to 3%, right? So very minute. The other thing I want you all to know is, guys, what are these made of? HbA1 is made up of 2 alpha chains and 2 beta chains. 2 alpha, beta, 2 beta. This is very important to remember. Okay. Then our HbA2 is made up of what? HbA2 is made up of 2 alpha and 2 delta. 2 alpha and 2 delta. Okay. Right. So now, based on this diagram, right? Thalassemia, guys. When we talk about thalassemia, is it usually a disease you diagnose in intrauterine life itself? Or do you all in the clinical setting, do you all meet the patients who are either like children or adults? What do you all think? Intrauterine life versus afterbirth. When do we usually diagnose thalassemia? Huh?
Around 6 months after birth.
Excellent. Right. This is what I wanted to say. So thalassemia, guys, the clinical features, they start appearing somewhere here, right? Around 6 months after birth. Why is this, right? Thalassemia that we are going to talk about is mainly a problem in this alpha and this beta chains, right? We are going to talk about something called alpha thalassemia, something called beta thalassemia. So this alpha and beta, right? Once the problem with this alpha and the beta is something called the alpha to beta ratio, right? Don't worry, we'll talk about all of this. Now, why does the patient start developing manifestation at around 6 months of age? At around 6 months of age, guys, you all can see this HbF, fetal hemoglobin, starts disappearing, while the adult hemoglobin starts increasing in number. Now, the problem in thalassemia is related to our adult hemoglobin. So the problem starts appearing around 6 months of age. Until then, the fetal hemoglobin covers and does the job, right? Until about 6 months of age, no problem. Even though the patient or even though the child has the genetic defect, right? There will be no manifestation. No manifestation. Okay, right. So that's the next one. Now, so we talked about all of these HB types, HbF, HbA1, HbA2, HbE, right? Around anything familiar somewhere around here? This is just extra now, since there are no first to third years, right? I'm taking a little bit extra, right? What is this HbA1? Has anyone heard anything similar to this with something like diabetes? Huh?
HbA1c.
HbA1c. What is this HbA1c, guys? Now, where is this hemoglobin found? Where are these types of hemoglobin are found? Inside our red blood cells, right? Red blood cells have the hemoglobin. This HbA1, once you add a sugar component to it, what we call glycation, right? It becomes HbA1c. HbA1c. Now, just this is out of today's topic. This out of today's topic, just for you all to recall these things. HbA1c indicates blood glucose control of how long? How long?
3 months.
Past 3 months. Excellent. The past 3 to 4 months. Past 3 to 4 months. Now, can you all think of some, come up with some mechanism? Or why does HbA1c only indicate the sugar levels of the past 3 to 4 months? Why?
Because the lifespan of the RBC is 120 days.
Excellent. So this HbA1, this is also found inside the RBC, right? And the lifespan of an RBC is about 120 days, usually 90 to 120 days. So that's about 3 to 4 months. Okay. Right. Good. Right. Just extra stuff for you. Right. Now let's come back to our topic. Now, so we talked about the fetal hemoglobin as well. 2 alpha and 2 gamma. Now, we said, guys, towards the first 6 months of life, the fetal hemoglobin starts dropping. Why does this happen? Let's take a look. Here, guys, in our body, we have a specific type of protein. We call this, write this down, zinc finger proteins, right? Zinc finger proteins, right? These zinc finger proteins, guys, these are some DNA binding proteins, right? They have a role to play. What they do is they come and inhibit the genes that produce gamma chains. They come and inhibit the genes that produce gamma chains. So what is going to happen? Gamma starts dropping. Gamma starts dropping. Whenever these zinc finger proteins are activated, gamma starts dropping. And coincidentally, these zinc finger proteins start getting activated by around the 4th to 5th month of life. Okay, right? Right. Now, when the gamma starts dropping, what is happening to this alpha? This alpha is now free. He doesn't have anyone to be with, to marry. Okay, so alpha is now alone. So what is going to happen? This alpha, once the gamma starts dropping, the alpha will see the betas here, right? And immediately go and bind to those betas. That is how the conversion from fetal hemoglobin to adult hemoglobin occurs around the age of 6 months. Okay, right? So who is the important role here? Zinc finger proteins. Because if zinc finger proteins are not there, we'll see some other conditions we are going to talk about today. The gamma chains won't drop if the zinc finger proteins are not there. If the gamma chains won't drop, there are some other pathologies that we'll talk about towards the rest of the class. Okay, right? Everyone understood up to this point, right? Give me a thumbs up, right? Okay, right, okay, good. Right. Then, guys, let's move on. Right. Now, the next point. Today, very hot, guys. Okay. Right. Okay. Any students here joining from China? Okay. Guys, give me a second. Right. Guys, I'm back. Can you all see me, hear me? All good? Yeah? All good? Okay. If there is any problem in hearing me, just let me know. Right? Okay. What to do, guys? We are in. Okay. Right. Back. Anyways. Right. Look at this, guys. Now, where did we stop? So we talked about the different forms of hemoglobin and how they change throughout the first year of life, right? Okay. Then let's move on, right? When we are talking about thalassemia, guys, we are going to mainly talk, right, about a specific couple of types, right? One is our beta thalassemia. This is the most common thalassemia, especially in Sri Lanka and most of the world, right? Most of the world, this is the most common form of thalassemia. Then we have what we call alpha thalassemia. Okay. And then, guys, there is another entity, right? You write this down. We'll talk about this also later. Called hemoglobin E, right? Beta thalassemia. This is a subtype of this beta thalassemia, right? In some books you all might see it called HBE beta, right? Or thalassemia E beta, right? We'll talk about this. This is a subtype of this beta thalassemia. We'll talk about that also, right? Okay. Then, the next thing. Let's start off with beta thalassemia, right? Look at this, guys. Let's put the topic beta thalassemia, right? Right. Beta thalassemia. This is the most common form, right? Now we know, just to recall, we know in a normal person, we have majority HbA1, right? HbA1. And HbA1 is made up of 2 alpha and 2 beta chains together, globin chains. Then we also have something called HbA2, right? This is made up of 2 alpha and 2 delta. 2 alpha and 2 delta, right? 2 alpha and 2 delta. Right. Now, look at this, guys. What is this beta thalassemia? This is a defect in the genes that are coding for the beta globin chain, right? So the beta globin chains are also proteins. They need to be coded for by some sort of genes. So there is a defect, some sort of defect in the genes, right? Some sort of defect in the genes, right? That are coding for these proteins, right? So let's take a look at this, guys. This problem is there in chromosome number 11, right? Chromosome number 11. So the genes coding for these proteins are there in chromosome number 11. So what is going to happen? Let's talk about the defect in a little bit. So the defect is there, the genetic defect, right? Because of this defect, what is going to happen, guys? The beta chains are going to be either reduced or they are going to be absent, right? Depending on the severity. We'll talk about the severity in a while, depending on the severity of the gene defect. So when the beta chains are reduced or absent, what is going to happen, guys? Now, to form our adult hemoglobin, what do we need? 2 beta chains are needed to join with 2 alpha chains, right? So when the beta is reduced or 0 or absent, what is going to happen? These alpha chains start comparatively and increase in number, correct? Because there is no one to bind with the alpha, right? This is the main problem, guys. We have what we call the alpha to beta ratio, right? This is usually a 1-to-1 ratio. What is going to happen if beta is absent? This ratio is offset. That is the main problem in beta thalassemia, right? That is what gives rise to the problem in thalassemias, right? The alpha to beta ratio offset. Now, if this is the case, what is going to happen? Let's take a look. one thing that can happen is, guys, alpha chains, right? One thing, alpha will start increasing within RBCs, within red blood cells. Alpha chains will start increasing, right? Because there is no beta to bind. The other thing is that alpha chains will bind to other forms of will bind to other globin chains, right? Alpha will bind to other globin chains. What do I mean by other globin chains, guys? We know now, we just talked about here also. Alpha can go and bind to delta. That is what HbA2. Alpha can also go and bind to what? Gamma. Two alphas will go and bind to two gammas. What is this? HbF, fetal hemoglobin. Now, these types of hemoglobin, what do you all think? Are they as functionally efficient as our HbA1? No. In the adult body, guys, we need HbA1, right? These aren't that functional, right? They don't do their job properly, right? Therefore, right, we are going to see some clinical manifestations here as well. The next thing, which is what? Alpha chains increase within the RBC. What is going to happen when alpha chains increase within the RBC, right? Now, you all know, guys, for our RBCs to be this nicely, let me draw this nice biconcave disc, right? We know the RBC has a nice biconcave disc shape, right? But this to be in the shape itself, the hemoglobin content inside this should be normal, right? And the hemoglobin structure should be normal, right? If those are abnormal, the RBC will also start looking something like that, right? Okay, that is how it is in our body. So when there is an increased number just of alpha in the RBC, the hemoglobin structures become abnormal. We know, and normal hemoglobin, we need about 27 picograms of hemoglobin per RBC. That quantities also become abnormal. So because of that, guys, the entire hemoglobin structure and the RBC structure, right? Structure becomes abnormal, right? Now, when hemoglobin structure and RBC structure both, hemoglobin structure and RBC structure both become abnormal. So when hemoglobin structure and RBC structure both become abnormal, what is going to happen, guys, right? First thing, what is the most obvious thing? Oxygen carrying capacity. What is going to happen to our oxygen carrying capacity? Oxygen carrying capacity drops, right? Because they are not efficient now. So the oxygen carrying capacity drops. Another thing is, guys, specifically with the structural differences, right? They are going to break down. Now, you all know, guys, where is one? Now, there are no junior students here. Where is one of the primary sites where RBCs are broken down? Where?
Spleen.
One of the primary sites. There are other organs as well in the reticular endothelial system, including the liver, right? There are other places as well, right? But one of the primary, most important sites is the spleen. Right? Guys, mute yourself after your answer. Okay, right. So one of the primary sites is the spleen. Now, what is happening in the spleen, guys? Inside the spleen, if I take let's say this is the spleen, I will just draw a rough diagram. Inside the spleen, guys, there are some of these lymphoid cells, very long shaped cells, something like this, right? If I draw, just for you all to remember, right? Let's make it easier. Let's say it's something like this, these long cells, right? You all can imagine like a cage, like a jail, right? Like a jail. What is happening is, guys, these are called cords of Billroth, right? These are special lymphoid cells within the spleen. What is going to happen is, guys, when the RBCs are nicely shaped, nice biconcave disc shape, beautiful central pallor, and the pink surrounding, when it is nicely there like this guy can easily pass through this, right? They can easily pass through the cords of Billroth and go in the circulation and do their function. But whatever is abnormal, whatever RBC structurally and functionally, whatever is abnormal will get stuck here, guys. They can't pass through this cage, right? They can't pass through this in the cords of Billroth, right? In the spleen. What is happening the moment they get stuck here? Who is residing right here? This is just like you all can imagine it like a inside a police department, right? The moment they get stuck here, who is here to eat them up? Macrophages are there, right? So macrophages will come and break down. So this is how, guys, structurally and functionally deficient RBCs are removed from the system. We do not need them. Such an efficient system, right? Okay. So that is what is happening. So here the same principle applies, right? When these RBCs are abnormal, shape, structure, function, everything, right? What is going to happen? They will get caught in these cords of Billroth and they will be immediately broken down, right? By the macrophages and the resulting cytokines that they release. What is going to happen? Hemolysis, right? Hemolysis. What is hemolysis? Breakdown of RBCs. Now, hemolysis. When it is happening in the spleen, what do we call it? What do we call it?
Extravascular.
Extravascular hemolysis, right? It's not happening inside the blood vessels. Excellent. So hemolysis happening inside the spleen, we call it extravascular hemolysis, guys. Extravascular, right? Extravascular. Now, what is the importance of this extravascular hemolysis? In extravascular hemolysis, guys, once the RBC is broken down, we are going to produce some substances, right? One of them is called unconjugated bilirubin. Now, don't worry if there are any junior students, right? If there are any junior students who don't know what unconjugated bilirubin is, don't worry, we will talk about this, right? When we talk about jaundice, that is a different chapter. That's a different chapter, right? For now, just know, when there is hemolysis, there is something called unconjugated bilirubin being released, right? That's enough. Then the next thing, again, when the extravascular hemolysis is occurring, another one that comes out is iron, right? From our heme, iron is going to be coming out. So iron is going to be released. Iron is going to be released, right? This unconjugated bilirubin, guys, right? When it is released into the circulation, right, it causes yellowish discoloration, what we call icterus or what we call jaundice, right? What we call icterus or jaundice, right? Okay, icterus. Okay, now, since there are senior students here, unconjugated bilirubin versus conjugated bilirubin. What is the difference in the jaundice or what is the difference in the icterus?
In unconjugated, it's mild.
Excellent. Excellent. Mild. And Karinda, where do we see it most in unconjugated?
The sclera.
Excellent. Sclera is the first place you're going to see unconjugated hyperbilirubinemia, right? It is what we call a tinge icterus, scleral icterus, right? Slight yellowish discoloration, right? Whereas if there is conjugated hyper, that's a different chapter. Don't worry. I'm just taking you all extra because today I know there are no first year years, right? In conjugated, right, we are going to get what you call the deep jaundice, right? We'll talk about this later, right? Anyway, so unconjugated hyperbilirubinemia, right? And therefore you're going to get scleral icterus primarily, but there can also be slight discoloration here and there in the skin, right? Okay. Then when the iron is released, guys, you all know what is going to happen. There is something called hemochromatosis. This iron can go and deposit in multiple areas, right? We'll talk about that in the clinical picture. There can be what we call hemochromatosis, guys, right? Hemochromatosis. This hemochromatosis, primary or secondary? What do you all think? Primary hemochromatosis or secondary?
Secondary.
Secondary. Why secondary? Why secondary? Why secondary? Huh? Why? Because it is happening due to a different pathology, right? You're not directly giving iron to the patient and seeing an iron buildup. No. Here what is happening? There is a different disease pathology going on. Due to that, RBCs are being broken down, and due to that, iron is being released. So it's a secondary cause. It's a secondary cause, right? Excellent. Secondary hemochromatosis, right? So secondary hemochromatosis also can occur. Now, what did we say on this side? Oxygen carrying capacity reduced, right? When oxygen carrying capacity is reduced, guys, right? What is going to happen, right? We are going to get hypoxia and anemic features are going to start manifesting. Anemic features, anemia, right? We'll talk about all these clinical features. Don't worry. Anemic features are going to come, right? Okay. Now, right, I should have started this a little bit higher, right? Guys, if you all drew this, continue the diagram. Huh? Now I'm going to erase a little somewhere here so that I can continue the diagram, okay? You all just continue downwards, okay? Look at this. Now, so what are we getting, guys? We are getting hemolysis and the reduction in oxygen carrying capacity, and we are getting anemic features. This hemolysis also contributes to these anemic features for obvious reasons. You all understand that, right? When we have anemia setting in and hemolysis going on, what is going to happen, guys? Now, you all can continue downwards. I'm just going to draw it here, right? What is going to happen is, guys, there is compensatory mechanisms are going to start up. Compensatorily, what do we want to do now? What does our body want to do as a compensation based on what is happening? What do you all think? Huh?
Hematopoiesis.
Excellent. We want to start producing more and more RBCs, right? Start producing. So for this, guys, now we know, right? Usually, where are majority of our RBCs produced? Where are majority of our RBCs produced?
Bone marrow.
Bone marrow. Bone marrow of what bones? Bone marrow of what bones?
Long bone.
Long bones, right? One of the prominent places is your femur, right? Bone marrow of your long bones. Now what is happening, guys? Here, in thalassemia, is there a problem with RBC production? There is a hemoglobin production issue, but the RBC production, do we have a problem? No. RBCs are produced normally. So what is happening? Now the bone marrow of these long bones are also still producing RBCs. It's just that they are producing, how can I say, ugly RBCs. They're producing ugly RBCs, right? Let's put it like that, right? So what does our body want to do, guys? It wants to start stimulating other areas to start producing RBCs as well, right? What do I mean by these other areas? Look at this, guys. Usually, RBCs are what we call medullary hematopoiesis, right? Medullary, the medulla of long bones, right? Medullary hematopoiesis, right? This is how we produce our RBCs, medullary hematopoiesis, the medulla of long bones. Now, what is going to happen? As a compensatory mechanism, this medullary hematopoiesis is going to increase. But the problem is, guys, not in our usual femur and all, right? They are already producing RBCs at their capacity, right? So what is going to happen? Signals are going to be sent to other bones, right? Specifically some flat bones in our body, right? Our sternum, our skull, right? These areas are going to be stimulated to produce more and more and more RBCs. They are not usually in the business of producing RBCs, right? Now they are doing functions out of their job description. So what is going to happen specifically? I want you all to remember the skull, right? Very important. The skull bones, right? Later we'll talk about the structure, right? They are going to be stimulated to start excessive production of RBCs, right? When that happens, guys, we will see some clinical features. The skull bones start expanding. They start expanding because they are doing a job that is not in their description. They are not used to it. So they start expanding, right? We are going to see what we call the thalassemic facies. Thalassemic facies, right? Facies, right? That is one. The next thing, that is when we talk about medullary hematopoiesis, right? Bone related. Then there is also a compensatory increase of what we call extramedullary hematopoiesis. What is this extramedullary hematopoiesis, guys? There are some organs in our body, not bones, other organs that are also having a minor role in RBC production, right? So for example, the liver, the spleen, they have minor roles in RBC production, right? They don't usually produce a lot of RBCs. Now what is going to happen? As a compensatory mechanism, those organs are also going to be stimulated to produce more and more and more RBCs, right? Specifically, I want you all to remember the liver and the spleen. So this is why, guys, we see when they are working, right? Liver and spleen are overworked and they are doing a job that is out of their job description, right? They are not used to it. They are going to also start expanding and increasing in size. This is why we see hepatosplenomegaly. Now, hepatosplenomegaly, guys, in thalassemia, there are multiple number of reasons. We'll talk about some other reasons as well that are contributing to this hepatosplenomegaly. This is the first reason. Okay, right? Okay. Specifically, guys, if I want to put a star around this spleen. I will tell you all why, right? The spleen, right, is very prominent when it starts erythropoiesis. Right? This guy is so not used to doing that. Right? He expands a lot, right? We will see. Prominent splenomegaly, right? Anyway. Now, all of these things, guys, and the manifestations that we have talked about here, everything will depend on the severity of the genetic defect, right? Now, we started with the genetic defect here, right? The severity of this genetic defect will determine all of this, how severe these clinical manifestations are. So let's next take a look at the genetic defect. What is this defect, right? This is what we're going to look at, right? Okay, here's this. What are these genetic defects? Let's start off with beta thalassemia. What is the genetic defect in beta thalassemia, right? Look at this, guys. If we take, now we said this is a problem for beta thalassemia, it's a problem in chromosome 11, right? Chromosome number 11. So if I draw chromosome number 11, I will draw 3 copies, right? You all also can draw, right? Something like this. Right. Another one. So you all know chromosomes have one short arm and a long arm, the P arm and the Q arm, right? This is what I have drawn here, right? And these are chromatids, right? The chromatids, individual chromatids, right? Now we will see. So the gene that codes for the beta globin chain. Beta globin is a protein. The gene that codes for the beta globin chain is present here on chromosome 11. Where are they present? Let's take a look. In a normal person, guys. First, let's start with a normal person. In a normal person, this gene is somewhere here, right? On both the chromatids, right? You can color something like that. The green, I have used green. Okay. This is a normal person, right? This is a normal person. So let's say capital B and capital B. Okay, capital B, right? Normal person. Then there are some people, guys. Look at this. One of them is green, right? One of them is green. So one capital B. And the other one is a defective, or what we call in the case of beta thalassemia, it's a point mutation. A point mutation. So this is going to be a simple B, right? A simple B. These are another group of patients. Then we have yet another group of patients, guys, right? Both of the gene loci have undergone point mutations, right? So it's a simple B, right? Simple B. Okay, right? Now, this is our thalassemic picture, guys. This is a normal person. This is us, you and I, right? Provided you all aren't diagnosed thalassemic, right? This, right? Where one gene is functional, but the other gene is dysfunctional, right? This is what we call thalassemia minor. Thalassemia minor, or we call it another word, guys, trait, right? So beta thalassemia minor or beta thalassemia trait, right? Then this guy, what is this guy? Beta thalassemia major, right? This is beta thalassemia major, right? Okay, right. Now, what did we say about beta thalassemia? This is an autosomal recessive disease. So for you to be affected by the disease, you need both copies of the gene to be dysfunctional, right? However, if one is dysfunctional, you can still have some manifestation. That's why we are calling it minor or trait. There can be some mild, sometimes they are even asymptomatic, but sometimes they can show mild symptoms, right? So this is the difference. Now, if I tell you, right, yeah, now here, everyone's seen, right? Let's say we have a mother and the father, right? Let's say we'll take this type, we'll take the trait type. Let's say both of them are trait, right? So B and simple B, capital B and simple B. Now, if you all do the cross, right? Since there are no first to third years here, right? If there is a first to third year, don't be shy, just drop a message. I'm going through all of these, right? Okay. If you do the cross here, right? You all can do the cross now. Tell me the chances of the next child also being first tell me the chances of them being a major, and then tell me the chances of them being a minor. Come on.
Major 25%.
Major 25%. Okay, minor
50%.
50%, right? Okay, so that is 1/4 and 2/4. No, so you all, I hope, guys, just give me a thumbs up. Just let me look at the faces. I don't want to skip through these parts. Huh? Everyone understands this, right? Everyone understands the cross diagram, yeah? Right? Okay, thumbs up, Shabib, all good? Yeah, okay, right. Okay, good. Right, excellent. So there's a 25% chance that the next child can also be a thalassemia major patient, right? Okay, right. So you all understand that. Then let's move on. Then, guys, we'll go to the specific types, the trait, the major, what is happening here, right? I hope you all understand the genetic defect now, right? Okay, so we'll go to beta thalassemia trait first, right? Thalassemia trait is the most common form, guys. More than thalassemia major, beta thalassemia trait is the most common form, right? So this is what we call the heterozygote. Why are we telling heterozygote? He had one capital B, one simple B, right? It's a heterozygous. The genotype is heterozygous, right? And they are what we call carriers, guys. They are carriers of the disease, right? Carriers of the disease. Okay, carriers of the disease. Now, what do you think? Now, what is happening, guys? When we have a beta thalassemia minor or a trait, the genetic defect is on one allele. It's on one gene locus, right? The other one is working fine, right? So what is the problem with beta thalassemia? Whenever we have beta thalassemia, beta chains are going to be reduced or absent. Now, when it is beta thalassemia minor or trait, what is it going to be? Beta chains reduced or beta chains completely absent? What is it going to be? Huh? Beta chains are going to be reduced. And that too, guys, not a very drastic reduction, just a slight reduction. So if that is the case, what do you all think about the alpha to beta ratio, right? Is it too bad? Not really. It's not too bad, right? There can be a little bit of a problem, right? But beta chains are not completely absent. There are some beta chains present, right? Okay. So because of this, guys, if the patient has beta thalassemia trait, they have mild anemia, right? Mild anemia. Okay, mild anemia. And if you look at their jaundice, The jaundice is also going to be very light. Why? Hemolysis is not happening to such a great extent, right? So jaundice is also very mild, right? The scleral icterus is going to be very mild, right? If you look at the RBCs, guys, in a blood picture, if you look at the RBCs, we are going to see what you call microcytic hypochromic anemia. Now, this is the same form of anemia that we see in iron deficiency as well, right? Okay, but there the mechanisms are different. We'll talk about iron deficiency anemia in another chapter, right? Here also you are going to see microcytic hypochromic cells, okay? Right. Then, guys, there is something called the reticulocyte distribution width. Now, what is this? What is this reticulocyte distribution width? If we take a look at this, now you all know RBCs, right? In a long bone, right? In a long bone, RBCs go through several stages, right? They go through several stages, right? Before finally coming to their small, tiny, nice biconcave disc shape and coming out into the blood, right? These are all about hematopoiesis, right? This is a different chapter, but just for you to get the basic idea. Immature RBCs are very large, guys. They are very large. The nice mature RBC, who is functionally adapted to do all the oxygen carrying, these guys are tiny, nice biconcave disc shape, right? Okay. So what is going to happen in the case of a thalassemia, guys? What did we say? The body is stimulating everyone. You produce RBC, you produce RBC, you produce RBC, right? So the body is in a sort of like a stress, right? And it's in a rush to produce RBC, right? So what is going to happen? Some of these immature states are also going to start coming out to the blood, right? So what are you going to see if you do the blood picture, guys? If you do a blood picture, you will see some nice tiny RBCs as well as you will see large RBC, immature guys also have leaked into the blood. Now, in a normal person, guys, right? The reticulocyte distribution width is about 15%. What do we mean by this, guys? If you take a normal person, if you take a blood sample in you and I, right? We will see if we observe under the microscope, right? We will see about 3 different sizes of blood, let's say, blood cells, RBCs, say size A, size B, size C. Size A is the best one. In a normal person, we can have around 3 different sizes, right? So if you take the reticulocyte distribution width, right? Something like this is the reticulocyte distribution width, right? The difference between the smallest RBC and the largest RBC. This is the width, okay? What is going to happen in the case of thalassemia, since the body is in such a stress and such a rush to produce RBCs as much as possible, all these immature different sizes, you will get multiple different sizes of RBCs coming in, right? Therefore, what is happening? The smallest size will be this, but you will have other different sizes, right? Such large sizes, the total reticulocyte distribution width will increase. So the difference between the smallest RBC and the largest RBC, right? The size difference is going to be very large. That is what we call the reticulocyte distribution width, right? So in thalassemia, we see an increase in reticulocyte distribution width. In minor also, we see thalassemia minor also, or trait, we see an increase, but not that much. We'll talk about the major. That is where you see the largest, right? Okay. So here also you will have a minor increase in the reticulocyte distribution width. Okay. Right? In majority of the cases, guys, in thalassemia minor or trait, reticulocyte distribution width is normal, right? That is what I want to point out, right? Because when we talk about major, we will see a large change, large reticulocyte distribution. Okay, so y'all can draw it like put like a dotted line here for the increase symbol, right? A dotted line, huh? Right? Like that, or normal, okay? Or normal, right? Is that clear? Right? Now, yes, any question?
Can you explain again why does the reticulocyte distribution width increase? It remains normal.
So, because in thalassemia minor, the genetic defect is not that much, right? We said the genetic defect, if you take the chromosomes, right? One guy is functioning normally. If one guy is functioning normally, we still have some beta chains being produced, right? If beta chains are still being produced, we can still form some of this HbA1. Why? Those beta chains, although reduced in number compared to a normal person like you and I, it's reduced in number, but still we have the possibility to form some HbA1s, right? So the hemoglobin production won't be abnormal. So this maturation process will also not be that bad, right? This is what I want. This is the difference between thalassemia trait versus major. It's a difference in severity, guys. trait versus major, the difference is the severity, right? Because of the genetic defect. So when that is the case, right, the RBC production and everything won't be that abnormal. Therefore, the reticulocyte distribution in most patients will appear normal, right? Like you and I. Sometimes you can get some patients with a slight increase, right? Next, we'll talk about major. Okay. Is this clear?
Okay, got it.
Right? Okay. Excellent. Then another point to talk about thalassemia minor, right? Trait. Here, guys, let me erase this a little. If you do now, I hope you all have watched the video on the iron profiles. We talked about iron profiles, right? Iron profiles. This is another diagnostic investigation where we check the serum iron of the patient, right? Different forms, right? In the iron profiles, what have we talked about when it comes to iron deficiency anemia, guys? We talked about several, components of the iron profile. So we have serum iron, right? We talked about serum iron, right? We talked about serum ferritin. We talked about something called the total iron binding capacity and the percentage saturation. So I hope you all know what these mean. Huh? If not, just go through the video. It's they are in the on the platform. Huh? Right. In iron deficiency anemia, now tell me what is going to happen to each of these. Serum iron, come on, unmute and tell me. In iron deficiency anemia, serum iron, what happens? What happens? Come on. Reduced. Serum iron reduced. Serum ferritin? Reduced. Total iron binding capacity? Come on. Increased. Guys, give me a second. Am I getting stuck? Let me. Give me a second. Right. Can you guys hear me? Guys, can you all hear me? Yeah? Okay. Sorry about this. What to do, right? Okay. Right. Okay. Where were we? Right. Percentage saturation is going to be also low, right? In iron deficiency anemia. Now, so we talked about these in the previous session. Look at this, guys. What do you all think happens in thalassemia trait? What do you think about the serum iron? Now, is there a big problem when it comes to trait, guys? Is there a big problem in your body's iron stores? What do you all think?
No.
No. You said no, right? Yeah. Okay. I'm hoping you said no. Right? Look at this, guys. When we talk about thalassemia trait, there is not a big problem in the body's iron, right? The body's iron. So if you look at the serum iron, this is going to be normal. There is also no problem in the iron stores. So if you look at the serum ferritin, this is also going to be normal. Is there a problem in thalassemia trait, right? Later we will talk about some liver issues that come with management of thalassemia major and all. But once we consider thalassemia trait, is there a problem with the transferrin production? There is no problem with transferrin production. So the TIBC is going to be normal, right? If you look at the percentage saturation, if transferrin is normal and there is no problem in iron, the percentage saturation is also going to be normal. In thalassemia trait, guys, if you do the iron profile, right, it will be normal unless, of course, the patient has some other sort of coexisting pathology of the liver or something like that. Almost all the patients will have a normal liver profile, normal iron profile, right, in thalassemia. In major, there can be some problems, right? I will talk about that when we come to the major, right? Thalassemia major, right? Okay, right. Everyone understood up to this point, right? All good, right? Okay, let me see some faces. Guys, everyone turn on your cameras, huh? Right? Okay, right. Let's move on. We'll go to, so we are done with beta thalassemia trait, huh? We are done with beta thalassemia minor. Let's go to beta thalassemia major, right? What is happening here, guys? This is the homozygous. What did we say? The simple B, right? So what is happening? If you look at the chromosome, both Both gene loci are abnormal, right? Both gene loci are abnormal. So there is going to be a severe reduction, right? If you look at the beta chains, they are going to be very, 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 very low. You all can even put it as 0, right? Almost no beta chain being produced, right? So severe anemia. What is the clinical picture? Severe anemia, right? They are going to be pale, right? There can be even breathing difficulty, right? Severe anemia, severe manifestations of severe anemia, right? And now, remember guys, we looked at the erythropoiesis process even in thalassemia minor or thalassemia trait. We said different sizes of blood cells can come into the blood and all of that. That is what we call guys ineffective erythropoiesis, right? When all these abnormally shaped RBCs are allowed to come into the blood, right, before they properly mature, we call that ineffective erythropoiesis, right? Ineffective erythropoiesis. Now, here in thalassemia major, we have massive ineffective erythropoiesis, right? Massive ineffective. So what do you see, guys? If you do the blood picture, right, you can see one thing, right? Profound microcytosis. So they also have a microcytic hypochromic anemia, but very severe, right? Profound microcytosis. Then, apart from that, right? If you look at the reticulocyte distribution width, what is going to happen? Multiple different sizes, right? So many, such a difference. So the reticulocyte distribution width will be very, very high, very, very high. Okay, right? Then, now, what is happening here, guys? The beta globin chains are absent, right? When beta is absent, what should alpha do? When the wife is not at home, what should the husband do? Right? Stay like a good boy, right? What is going to happen, guys? Right? Alpha will go and bind with other stuff, right? Will go and bind to other things, okay? Right? Now, what is it going to bind with? Alpha will go and bind to delta, right? Alpha will go and bind to gamma. So if you take this patient's serum and if you do an electrophoresis, right, you are going to see other forms of hemoglobin. You're going to see other forms of hemoglobin. If it binds to delta, we call it HbA2. So hemoglobin A2 is going to be increased. If it binds with gamma, we call it HbF, right? Fetal hemoglobin is going to be increased, right? Okay, drastically. Then, guys, one other characteristic feature of this thalassemia major, right? We have, right, if you look at the blood picture, you're going to see RBCs like this, right? And now, what is happening, guys? They have a lot of abnormal hemoglobin being produced, right? These abnormal hemoglobins, guys, they don't occupy much of the space of the RBC. Now, you all know in a normal RBC, the hemoglobin is nice, right? Nicely pink there with a central color. Here also, you have a central color, but the hemoglobin is not accommodating all that space, right? Because those structures of those hemoglobins are different, right? So what you're going to see is a thin pinkish area. You're going to see the central color and you're going to see a thin pinkish area. And now what is happening, guys? There is a lot of space here, right? There's a lot of space here, right? So to accommodate this space, as the RBC wants to maintain its normal size, what is happening, guys? This is what they have found through research. These membranes, RBC membranes, start thickening up. They start thickening up to acquire this space so as to keep the RBC shape usual, right? Okay, like this. So what are you seeing, guys? You are seeing a thick outer reddish appearance. Then you're seeing a whitish area. Then again, you're seeing another reddish appearance followed by another whitish area. What does this look like? If you take a normal RBC, it looks something like this, right? This is what a normal RBC looks like, right? Just a central pallor region and the rest of it is reddish in appearance. Now here, what are you seeing? Red, white, like that. What is this called, guys? This is called a target cell, what we call a target cell or what we call podocytes or target cells, right? This is characteristic in thalassemia major. Occasionally, we can see 1 or 2 in thalassemia minor as well, but characteristic in thalassemia major. Okay, right? So this is another one. Then, guys, again, here, what do you think about the hemolysis in thalassemia major? Hemolysis is going to be severe, right? Severe hemolysis. So when there is severe hemolysis, what is going to happen? Again, anemic features will be severe. That is true. At the same time, right, they will have a lot of yellowish discoloration, right? Right? So they can have, again, presenting with icterus and jaundice, right? These kind of things. And they can also have hemochromatosis as iron is being released, right? Hemochromatosis. So we've talked about all of that, right? Now, tell me this, guys. If we take thalassemia minor, right? What do you all think? Is it usually diagnosed during thalassemia minor, thalassemia trait? Is it usually diagnosed during childhood or in adult life? What do you all think? Childhood or adult life?
Adult.
Adult life. Why? Why?
Because still a little bit of beta chain is there. So
Excellent. Excellent, right? So it's just the basic thing, guys. Usually thalassemia, what did we say about thalassemia trait? They are almost asymptomatic, right? Very minor symptoms. So you don't even notice, right? If you guys have, anyone here has kids, okay? If you have a kid, right? And the kid runs around the garden and comes and tells you, I'm tired. Are you going to think, okay, this guy is thalassemic? No, right? He might have some minor features of anemia. You will never suspect, right? So usually thalassemia trait is sometimes even accidentally diagnosed somewhere in adulthood, right? Thalassemia major, where do we diagnose? At 6 months of life. Immediately, right? As the conversion from HbF to HbA starts, you're going to start seeing the severe clinical manifestations, right? Okay, so that's the other difference there, right? So when you have a severe hemolysis, severe anemia going on, starting at 6 months of life, what are we going to get, guys? Write this down. We are going to get something called failure to thrive. Failure to thrive, right? Specifically in these infants, in these children, all right? Failure to thrive. What is going to happen, guys? Due to this chronic hypoxia, right? They are not going to grow, right? Bone growth will also be reduced. Actually, guys, they are very short, right? Short stature is also a noted feature, right? Short stature. Then apart from that, there can be, when they are with the failure to thrive, guys, they're going to have hormonal imbalances. With the hormonal imbalances, they can have developmental issues, right? So secondary sexual characteristics won't appear. Now, if you all have seen a thalassemic patient, right? A thalassemic patient of about 20 to 25 years of age, right? They appear like they're in high school, guys. The external appearance appears like they're in high school or middle school, right? Right? Because these secondary sexual characteristics don't appear. In males, there is no facial hair, nothing, right? Okay. So all of this is going to happen due to this severe condition, right? Is everyone clear about this? Is everyone clear about this up to this point? Right? Right. Let me see some faces. Guys, turn your cameras on. So I have told the co-host also to remove you all if you all are not. There were some issues, right? Just keep your cameras on. Okay. Right. So everyone's clear about beta thalassemia. All good. All good. Right. Let's go to alpha thalassemia. Right. We are not done now. We are going into a little bit deeper stuff regarding this beta thalassemia as well. But we are still in the basics. The CC, core concepts part, right? Alpha thalassemia. What is this alpha thalassemia? Just from the name, if someone asks you, okay, now you have come to your Viva exam. What is alpha thalassemia? Come on. I'm your examiner. Come on, say something. What is alpha thalassemia? Just put it into words, guys. I want you all to get the practice of putting things into words. Answer.
OMs and alpha chains.
Excellent. There is some problem in the alpha chains. So what is happening here, guys? Again, this is an autosomal recessive. All of these thalassemias are autosomal recessive. So there is an autosomal recessive problem regarding the genes that are responsible to produce alpha chains, right? Okay, so let's take a look at what is happening here. Here, guys, there is a problem. If we look at the chromosome number 16, right? Chromosome number 16. Now, beta thalassemia was chromosome number 11, right? Here, what is happening? Here, guys, if you look at the gene loci, this is duplicated on each of the chromatids. What do I mean by that? Look at this. If I draw the gene loci something like this, right? You also can draw, same thing. The gene loci are duplicated. It looks something like this. So in each chromatid, there are two gene locations, right? To produce the alpha chains in each chromatid, right? This is what is special about this alpha, right? Now, what did we say was the genetic defect in beta thalassemia? It was a point mutation. The problem in alpha thalassemia, guys, this is not any mutation. This is straight up deletion. This is a gene deletion, right? Gene deletion. So if we look at a normal person, what is he going to have, guys? You and I, what are we going to have? Alpha, alpha, and alpha, alpha. 4, right? 1, 2, 3, 4. This is what we have. This is what we have. Correct? If you look at an alpha thalassemia patient, there can be several varieties, guys. Let's take the first one. One of the alpha genes are deleted. So what will it look like? Alpha, 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 and blank. One of the alphas are deleted. One of the alphas are deleted. Right? If you look at another patient, let's say two of the alphas are deleted. If it is two deleted, what does it look like? Either there are two possibilities. One is like this and this, or it can also be what? Both of these are there, but both of these are gone. Right? One of these can be there. Right? Two alpha gene deletions. Right? Then what is the third one? The next one. Three alpha genes are gone. What will that look like? One alpha is there. This is gone. This is gone. This is gone. Three gene deletions. Okay. And the final one is all the alphas are deleted. Okay. So these are the possibilities when it comes to this alpha thalassemic gene deletions, right? Gene deletions. Now, what do I want you all to understand? This is the normal one. Huh? This is normal. Right. What do I want you all to understand here, guys? This one, the first one, right? The first one here, guys, this is what we one gene deletion. We call this alpha thalassemia minima, right? Alpha thalassemia minima, right? The second one, when there's two gene deletions, right? Two gene deletions, we call this alpha thalassemia minor. Now, in most books, guys, they will put both of these into one term and call it alpha thalassemia trait, right? Both of these are considered as alpha thalassemia trait, just like our beta thalassemia trait, right? So minima and minor is a little bit more specific, right? Then if three are deleted, we call this a special name, guys. Just write it down. I will teach you what this is. We call it HBH disease. HBH disease, right? HBH. Okay. And if four are deleted, right? This is our alpha thalassemia major. Alpha thalassemia major, right? We also call this Bart's disease. I will come to that. Just leave that, right? So these are the main types of thalassemia. We have trait, HBH, and thalassemia major. Right? Now you all know the gene deletions as well. What is going on here? Look at this, guys. Trait. How will they come to us? How will the trait patients come to us? What is happening here? Alpha is less. Alpha is reduced. Then to produce HbA1, what do we need? We need beta coming and joining to alpha. But now alpha is less. Right? So comparatively, beta is going to start increase. Okay. So what is happening to the alpha to beta ratio? That is going to be offset. Now that is where we started off, right? Whenever the alpha to beta ratio is gone, there is going to be clinical problems coming up, right? Right. Now, trait patient. How is he going to come to us? How is the alpha thalassemia trait patient coming to us? Come on, unmute and talk.
Asymptomatic or mild symptom.
Asymptomatic or mild symptoms. Excellent. Excellent. Just like our beta thalassemia. Just like our beta thalassemia, right? Excellent. Then, let's talk about this HBH disease. What is this HBH disease? Here, alpha is low, right? Alpha is low. Alpha is not zero. Alpha is low, very low, right? Because three alpha gene deletions are there. So alpha is very low, right? So what is happening here, guys? Just, I want you all to remember, right? When alpha is very low, beta gets so depressed, beta goes and marries itself. Okay. Now we find these things also, right? Have to be very careful in online class, right? So beta will marry itself, right? Beta, 2 beta with 2 beta, right? 2 beta with 2 beta. This guy, these 2 beta and 2 beta join together, guys, right? We call this HBH disease, right? They are going to come with some moderate degree of anemia, Okay, moderate degree of anemia. Then look at this alpha thalassemia major. Do we have any alpha chains being produced? No. All the genes are deleted, right? If that is the case, right? Very severe clinical manifestations, right? Here, guys, what is the important point here? Now, in the third one, right, in HBH disease, we had some alpha was there. Some alpha was there. Agreed? When there was some alpha, guys, during the first 6 months of life, what do we need? We need what we call HbF. HbF. What is HbF made up of? What are the two chains? HbF? Come on.
Alpha and gamma.
2 alpha, 2 gamma, right? 2 alpha, 2 gamma. So in this third scenario, right, gene deletion, 3 gene deletion scenario in HBH disease, at least during the fetal life and at least during the first 6 months of life, they have a little bit of alpha so that they can make a little bit of HbF. Agreed? Agreed. They can make at least a little bit of HbF. Here, can they make even a little bit of HbF? HbF needs 2 alpha, to join with 2 gamma. They might have gamma, maybe no problem, but they don't have alpha at all. Therefore, guys, they cannot form HbF. Fetal hemoglobin will not be formed. Therefore, what is happening? In the embryonic stage, if the child is having alpha thalassemia major, will they survive? No, right? This is what ends up in what we call hydrops fetalis, right? Hydrops fetalis, right? This is incompatible with life. Okay, incompatible with life. Okay, right? Sometimes, rarely, right? Majority of these babies, guys, right? Intrauterine death, right? IUD, right? They'll be stillborn. However, there are some cases, very rarely, the child is born alive, right? Child is born alive, but within there is severe hepatosplenomegaly, right? Severe anemia, heart failure, everything is there, right? Because of that, within few hours after being born, they will die, right? Basically, what I want you all to know, incompatible with life. Thalassemia, alpha thalassemia major, right? Okay. Beta thalassemia major, is that the case? No, beta thalassemia major is not incompatible with life, right? There is no issue there, right? We can treat, we are going to talk about transfusions, we are going to talk about chelation, we'll talk about all of that. Alpha thalassemia major, they won't survive. Okay. Right. Is everyone clear about this? Right? Here, guys, what is forming if they cannot form this HbF is, now in HbCs, what did we say? The 2 beta goes and marries itself, right? 2 beta goes and marries itself. What is happening in this O-alpha gene mutations, guys? There is a special type of hemoglobin being produced, which is formed by 2 gamma and 2 gamma. These are a little bit extra, right? Not really necessary for us to know. This is called HB-Barth, right? HB-Barth. This is why we call this Barth's disease, right? We call this Barth's disease. This Barth is the guy. This hemoglobin form has 0 affinity to oxygen, guys. It cannot take any oxygen. Absolutely useless hemoglobin, right? So that is the reason why these children are going to die, right? There is incompatibility with life. Okay, that's just some extra points, not really necessary for us to know, right? Okay, is everyone clear up to this point? All good, right? All good, right? Okay, let's move on. Let me take this here. Very scared to erase this area. Writing this thalassemia takes about another half an hour, right? Okay. Right. Look at this, guys. What are we going to do next? Next, we will talk about something called thalassemia intermedia. Thalassemia intermedia. This thalassemia intermedia, guys, we are not concerned with alpha forms. Alpha thalassemia intermedia, we are not confirmed. We don't need to talk about it. First thing is what alpha thalassemias are very rare, right? When you consider the thalassemias, beta is the major one. And out of the thalassemias, these intermedias are even rare. So we are not even going to talk about alpha, right? We are going to talk about beta thalassemia intermedia, right? Beta thalassemia intermedia. What is happening here? Look at this, guys. What is the problem in our beta thalassemias? Beta chains are low, right? Therefore, comparatively, alpha starts increasing and the ratio is offset. Everyone is clear up to this point now? Now look at this. What is happening in this thalassemia intermedia, guys? Our beta chains are low. However, due to some cause, listen very carefully. Due to some cause, this alpha increase is not allowed to happen, right? Due to some cause, this alpha increase will not happen, right? Therefore, what is happening? Now, what is the problem with thalassemias? Ratio offset. The ratio becomes offset. That is what is the main issue. Now, when alphas don't increase that much, due to some reasons, we'll check the reasons. What is happening? The alpha to beta ratio is okay. It's all right. It's not that bad, right? Therefore, the clinical manifestations become a little bit milder, right? Milder. So let's take a look at what these scenarios are. First thing, guys, you all can write down. If we have a beta thalassemia major patient, right? Beta thalassemia major patient with a coexisting alpha thalassemia, What will happen? Now, come on, tell me. If they're having beta thalassemia major, what is happening? Their beta is almost absent, right? Beta is almost not there, right? Very, very, very low, right? Alpha thalassemias, any degree. We don't really care about the degree, right? We talked about multiple gene deletions. It's okay. Anything. What will happen? Alpha will also be low. So what do you all think about the alpha to beta ratio? Offset is not that bad, right? Everyone agrees, right? Okay. Then another example. Let's say we have, again, a beta thalassemia major patient, Now you all will tell me. Plus, listen carefully. zinc finger protein defect. Zinc finger protein defect. Now tell me what is going on here. Come on. We talked about zinc finger proteins at the start of the class, right? What is happening? Huh?
A lot of gamma chains will be there, so alpha will combine with the gamma, and the alpha thing will go down.
And the
Alpha will go down, so the ratio will be
right. Excellent. They are having beta thalassemia major, so their beta is low, very low, or 0. But they are also having a coexisting zinc finger protein defect. What was the function of zinc finger proteins? They inhibit gamma. Production. If zinc finger proteins are defective, they are not going to inhibit gamma. So what is happening? Gamma increases. So much of gamma is present. Now here, when beta is lost, there was a lot of alpha present, right? And now what can happen? This alpha can go and bind with this gamma chains to form 2 alpha. What is 2 alpha and 2 gamma? Huh? This is HbF. So alpha increase. Now the ratio, our problem is if alpha increases too much. Our problem happens if alpha increases. Now what is happening? All the alpha is being bound to gammas. So again, the ratio offset is not too bad. Okay, clear? Is everyone clear about this? Right? This is very important to understand. So how will the patient come to us? The patient's clinical manifestations, guys, they won't be as mild as a trait, right? They won't be as severe as a major, right? Why? Ratio offset is not too bad. That is the line I want you all to remember. Therefore, they are going to come with some moderate symptoms of anemia, right? That is why we call it thalassemia intermedia. Now, the important thing here is, guys, when we talk about intermedia, we call this a non-transfusion dependent thalassemia. Now, if you take thalassemia traits, do they need transfusions? They don't. Thalassemia traits will not need transfusions. If you take thalassemia majors, those are transfusion dependent. They need transfusions, right? We'll talk about the frequency and everything. They need transfusions. Whereas when we talk about thalassemia intermedia, these are non-transfusion dependent. What does that tell you, guys? Occasionally, right? Throughout the year, maybe once, right? Or twice sometimes, they might need a transfusion. Apart from that, no. That's why we call it non-transfusion dependent thalassemia. Okay. Right? Did everyone understand up to this point? Right? Come on, let me see some faces. Dinita Gangodevilla. Which year? Dinita Gangodevilla? 3rd year. Which university?
Srijagannapuram.
Oh, right. Excellent. Right. Is it clear? 3rd years. All good? Right? All this content? Okay. Right. Then let's move. Right? Look at this, guys. Next. Right? We'll come to the diagnostics. Right? We're going to talk a little bit about the diagnostics. Look at this. Right. Look at this, guys. Right? Diagnostics. Clinical manifestations. We're going to talk about some clinical manifestations. Look at this. If we talk, we'll start with beta thalassemia trait. Now, we've already talked about majority of this content, right? What did we say? Mild or no anemia, right? Okay. If you look at their symptoms, they're often asymptomatic, right? Let's just write this down now. I will not write everything because it will take time. They are mild or no anemia and often asymptomatic, right? Similar to alpha, even alpha thalassemia trait is the same. Alpha thalassemia, that's why I just wrote trait because alpha and beta both similar picture, right? And if you are looking at the jaundice, you all can have a mild, often you won't even see the jaundice, but sometimes mild icterus will be there, right? If we look at the major, guys, if we look at beta thalassemia major, right? What is happening here, right? Hemoglobin is going to be drastically low, right? Therefore, features of anemia will be a pale skin, pale mucosa, right? If you look at this under the eyelids, you will see, right? Pallor, right? And they can even have features of, depending on the severity of the anemia, they can even have features of heart failure. Heart failure can be also there, right? Then, what is another thing we said? So that is about the anemia. Another thing we said is, guys, they have what we call extravascular hemolysis, right? Severe hemolysis is happening, right? So what is going to happen? We said unconjugated bilirubin is going to increase, right? When unconjugated bilirubin increase, icterus will be there. Icterus jaundice will be there, right? Usually involving both the sclera and the skin, right? Okay. Then, about the bone marrow RBC production, right? What did we say? Other bones, right? Out of their job description. That's how we talked about it, right? They will be recruited, right? Medullary hematopoiesis, other bones will be. So here we have bone expansion phenomenon, right? Bone expansion. What are these guys, right? The thalassemic species that we talked about. Now, let me share the screen, right? How do I do this? Guys, just give me a thumbs up when you all can see the screen. Huh? Let me. Either getting old or technology is getting too advanced for me. Every day some problem. Right, let me. Can you see the screen, guys? No, not yet. Okay. Can you see the screen? Yeah? Okay. Excellent. Excellent. Give me a second. How do I... This is your skeletal note. Huh? I've just put it up on the screen. Let me take this here. Can I see you all? There we go. I can see you guys also. Right. Look at this, guys. Let me take my pen. Guys, can you all see what I'm writing? Yeah? Okay. Right. Excellent. Look at this. Let me take this, right? Now, if you look at these few pictures that we've drawn here, right? We are going to, basically, I want you all to take a look at this thalassemic facial features, right? Here, guys, right? You all can see, what can you all see? Okay, let's take this child first. Let's take this child first. Child number 1 here, right? If you see this child, what are some things you can see here? Any bone expansion phenomenon that you can see here?
Frontal bossing.
Frontal bossing, excellent. Frontal bossing. Okay, anything else? Frontal bossing. What else?
Prominent maxilla.
Prominent maxilla, maxillary prominence. This area, the maxilla has come forward, right? The maxillary bone has come forward, right? Okay, these areas, right? Okay, what else? Anything else?
Flat nasal ridge.
Flat nasal ridge, right? The nasal bridge is flattened. It's flattened out here, right? Flattened out here. Okay, now even in this kid, you can see all of these. Okay, right. Anything else? Anything else? Now look at the other pictures also. Anything that you all can see? 2 and 3 or anything that you all can see?
Maloccluder teeth.
Maloccluder teeth, right? What do we mean by this maloccluder teeth, guys? What is maloccluder teeth? You all know, guys, our teeth, when we close the jaw, right? When we close our mouths, usually if we look at if I draw a side view, right? Something like this. Let me draw some. Let's say this is our jaw, right? Usually, there is, if you take our, the incisors from the upper jaw, right? From the upper set of teeth, it will be slightly in front of the lower set of teeth, right? Something like this. Now you all can close your mouth and check. Okay? It will be slightly in front. Okay? Everyone agrees? Right? If not, maybe there's another issue, huh? Right? Okay. Okay. Give me a second. So, and the remainder of the teeth, guys, they fall into these gaps like this, right? They are nicely within this is the proper occlusion of teeth that we have in our jaw, right? In the side view, I'm drawing a side view, side view. What is happening with this maloccluded teeth, guys? Because there is maxillary prominence. What do I mean by maxillary prominence? The maxilla starts moving forward, right? So it's going to appear something like this, right? Maxilla starts moving forward. This is the lower jaw, right? And these teeth are going to be protruding outwards, whereas the lower jaw teeth is still here, right? This is what we call a large overbite. We call this a large overbite, right? Okay, so the maxillary prominence, because the maxilla is moving forwards, right? Maxilla is expanding forward. It is taking along with it, right? The teeth, right? So the teeth are going to be what you call maloccluded teeth. See, now in these children, you can see the teeth are coming out of the mouth. They can't actually close their mouth, right? This child, of course, guys, there is a parotid enlargement here as well, right? Just ignore that, right? I got this from an online source. What I wanted to share with this child number 3, how old do you all think this child is? This was from an online case. I just downloaded the image. How old do you think this person is? This is, guys, according to that case, it was a 17-year-old. Can you all see this child as a 17-year-old? You know, he appears like he's in school still, right? Okay, so this is what we said about the developmental failure to thrive, right? Changes in thalassemia. Now here, the maloccluded teeth, here you can see it better, guys. See, you all can see this teeth has come forward, right? The upper jaw, right? It has moved forward, right? Okay, that is maloccluded teeth, right? Is this clear? Right. Let me stop sharing. Right. So back to the class, right? Okay. Then the next thing is, guys. So get my markers. Right. Now, right. Guys, if there is any connection issue, just drop a message to any of the admins, huh? Okay. Don't drop messages to me. I won't be reading it. Right. Okay. So we talked about hemolysis increasing. So there's going to be jaundice. We talked about the bone marrow bone expansion, right, in medullary hematopoiesis, right? So there's going to be these thalassemic facies, what we also call the chipmunk facies. Chipmunk, right? Their face looks a little bit like a chipmunk face, right? So you are having abdominally protruding teeth, maloccluded teeth, frontal bossing, prominent maxilla, right? A flat nasal bridge, right? These kind of things. Maxillary prognathism. This is what we talked about. It's causing the overbite, right? Okay. Now, another thing, guys, we said there is going to be extramedullary hematopoiesis as well, increase. So what do we have? Splenomegaly, right? Splenomegaly, massive splenomegaly can be there. Right? And then we said there's going to be growth retardation, failure to thrive, short stature, right? There can be secondary sexual characteristics delay, right? And guys, because of all of this, right? Later we'll talk about some reduction in quality of life regarding the treatment as well. But what you're going to see is, guys, these patients, these children specifically, right? There can be developmental regression and poor academic performance as well, right? So this is important in your history taking. Mother might come and tell you, my child is last in the class. That's the only complaint, right? So it's up to you to go from there to a diagnosis of thalassemia. Okay, we'll talk about history taking, don't worry, right? Right? Okay. Then alpha thalassemia major, what did we talk about? Hydrops fetalis, incompatible with life, right? So that also you all can write down, alpha thalassemia, hydrops fetalis, right? Then, guys, in the thalassemia intermedia, what did we mention, right? Mild to moderate features, right? Splenomegaly can be there, again a moderate splenomegaly, right? Bone deformities can be there, but won't be this prominent, right? Okay, so these kind of things can be there. Now, what do I mean by mild to moderate splenomegaly, guys? Now, if we take this as the abdomen, umbilicus here, you all know the spleen is somewhere here. When splenomegaly happens, it starts coming out. Spleen is in my left side, right? It starts coming down, diagonally down, like this, towards the right iliac fossa. That is how splenic enlargement happens. So like that. That is how splenic enlargement happens, right? So if it crosses the midline, we call this a massive splenomegaly, right? Massive splenomegaly. Okay, right? So this is important in your physical examination, right? Then, so those are some of the basic clinical manifestations. The next thing is, guys, laboratory diagnostics, right? Look at these labs. What are we going to look at in our lab diagnostics? First thing, you all can do a full blood count, right? We can all do a full blood count to look at the hemoglobin, right? Right? The hemoglobin levels will be low. So that's the first thing. Okay. Now, the next thing, guys. We take a blood picture. What are we going to see? Microcytic hypochromic anemia, right? And what can we see in the majors characteristically? In beta thalassemia major, characteristically, podocytes, right? Podocytes, or target cells, what we call target cells, right? Okay. Just remember, guys, if there is a true or false statement, podocytes are only seen in beta thalassemia major. True or false? False. False. Remember that. Okay. It can be seen, but it's characteristic in the beta thalassemia major. Okay. Right. Then the next thing. If we take an X-ray, right, we can see what kind of bone expansion features, right? So skull X-rays. If we take a skull X-ray, what are we going to see? We are going to see the frontal bossing. We can see the maxillary prominence. If you take a side X-ray of the skull, you can see a maxillary prominence. Then there is one more, guys. Let me share the screen again. right? I have put a X-ray in your notes. Just take that out. It's right here. Can you all see the screen, guys? All good? Let me move this here. Right. Can you all see the X-ray? Yeah, all good? Right. Look at this, guys. Firstly, if we look at the skull, right? Actually, if we look at the, let's take a look at the hand, right? Here, guys, we see sclerotic changes, right? This, if you all take a look at a normal X-ray, you all won't see this much of a whitish appearance. This much of a whitish appearance you all will not see, right? In the bones. This is happening due to bone sclerosis and bone expansion, right? This is one of the first things I want you all to know, right? The other thing is, guys, if you look at this skull X-ray, right? What can you see here? What can you see here? Now, this right here is the margin of the skull. Also, what can we see? We can see another very irregular, hazy appearance on top of that skull margin, right? What is this, guys? This is, look at this, this is what we call hair on end appearance. How is this happening, guys? If you take the skull bone, right? If you take the skull bone, we have something called the inner table and the outer table. This is the outer table, right? Outer table and the inner table. This is in a flat bone, right? In our skull, right? If you look at the middle, guys, there is what we call this trabecular bone, a trabecular bone here, right? Okay, right? Something like this, trabecular bone, right? Now, what is going to happen, guys? This is also what we call the diplo, the diplo of these bones, right? The diplo. What is going to happen is, guys, right? When there is hyperstimulation for this medullary hematopoiesis, right? What is going to happen? This diplo or this trabecula are going to start growing, right? In various directions. One of the easiest directions it has is upwards. So it's going to appear like lines, guys, like lines, right? Extra growth of trabecular bone, right? This is what we call, it grows towards the outer table. This is what we call this hair on end appearance, right? Right. Yes, can you all still hear me? Right, guys, can you all hear me? All good? Yeah, okay. Sorry about that. Y'all can see me also, right? It's okay, guys, right? This is is the challenge, right? Okay, let's go on. So where did we stop? Right. Yeah, the diagnostics, the X-rays, right? Okay. Then, now, what do you all think? These skull changes, these prominent maxillary changes in X-ray and all, will you all see in thalassemia traits? No. These you all see mainly the thalassemia majors, right? Then the next thing is, guys, there is a gold standard test that we have, right? This is what we call high performance liquid chromatography, right? Okay, high performance liquid chromatography, right? What is happening here is, guys, you take the samples, right, out of their blood and you put them in these chromatography papers, right? And you check for the type of HB. Now you all will see, right, like this in the chromatography, you all will see like this, right? So this is HbA2, this is, let's say, HbA1, and let's say this is HbF. Just a question, guys, since there are senior students here. HbF, in a normal person, what is the concentration of HbF we have, fetal hemoglobin? Normal person. Huh?
1 to 2%.
Yes, excellent. 1 to 2%, right? 1 to 2%, right? Very low, right? Okay, so we are going to see something like this, right? Now in thalassemia, what is going to happen? HbA1 is going to drop, So you can draw HbA1 at the lowest, right? And the other ones will increase. Now, guys, so this high performance liquid chromatography was considered the gold standard some years back. Now, still it is the gold standard and it is more available, but now we have a newer test, guys, called capillary electrophoresis. Capillary electrophoresis. Similar, right? Again, we get a graph like this, right? But what's the difference, guys? Here in the high performance liquid chromatography, if you look at the frontal, what we call the frontal edge, right? When this electrophoresis is moving, right? It's something like this, no? It's going in this direction, right? This is how you see. Okay, let me draw it upwards, otherwise you all will get confused. Let me draw it like this. In the electrophoresis, the high performance liquid chromatography, if you are seeing the field, it's going something like this. It's moving like this. So the frontal field is something like this, guys, right? It's a curve. That's why you get this curved shape areas like this. Whereas this capillary electrophoresis is very much more accurate, guys. The frontal field there is like this. It's a straight line, right? It's a straight line. So what are you getting in your electrophoresis result? In capillary electrophoresis, you will get peaks like this, right? Okay. Peaks. We are cutting out all these abnormal, we are cutting out all this unnecessary stuff, right? So that is why it is more accurate, right? So this capillary electrophoresis is now available, right? Even in Sri Lanka, right? Available. We are using this pediatric setup, right? We use this a lot. Okay. Right. It's more accurate than HPLC. Okay. Just remember that, right? Then guys, we'll just discuss a little bit about the management. Everyone clear up to this point, right? All good, all clear, right? Okay. Look at this. You can see, right? Everything is fine, guys. Just wishing the weather was about 2 degrees colder, right? Very difficult to work without a fan, no? Right? Okay. Right. So we'll talk about the management. Right? Look at this, guys. In the management, specifically, we are going to start treating the symptomatic thalassemias, guys. We won't even diagnose thalassemia trait in some patients. So we will start treating the symptomatic thalassemias, right? So one of the first things that we want to do is, guys, right? I will come to the specific management, but before that, right, just some added points for you all. We have to put these patients on long-term folic acid supplementation, right? Because what is folic acid, guys? This is vitamin B9, right? B9, right? So for DNA synthesis, right, for the RBC production, right, we want to improve it as much as we can. So we put them on long-term folic acid supplementation. The other thing is, guys, the mainstay of treatment for thalassemias, for the symptomatic thalassemias, is our blood transfusions, right? Blood transfusions. Now, right? Look at this, blood transfusions. Why are we doing the blood transfusions, guys? Because what is happening? Our patient is having ineffective erythropoiesis. Therefore, HB is low, RBC counts are low. They are going to get anemia. So because of that, we must replenish the blood store. So we are going to give them blood, right? Very simple, no? What is our target hemoglobin, guys? What do you think is our target hemoglobin?
It's 14.
Yes. Excellent. So, Tarinder, 10 to 12, this was a couple of years back, right? Now our latest, according to the latest guidelines, our target hemoglobin is 40, right? 40. Those days it was 10 to 12, good, right? So our target hemoglobin now is 14, right? So, usually, guys, in a thalassemia major, almost every 4 to 6 weeks, we'll have to transfuse the child, right? So this is a known thing. What I want you all to understand is one important question, specifically in Vivas also, they like to ask this, and you all should know as well, for your exams. After the exams, of course, if you're not a pediatrician, it's okay to forget it, right? What they like to ask is, guys, in these Vivas, they like to ask, how much blood, how are you going to decide how much blood are we going to give the child, right? This is a very common question. For this, guys, we need to calculate. There is an equation. How much blood to give. So the blood needed in milliliters, right? The blood needed in milliliters, how we calculate it is, guys, what we call the expected hemoglobin, right? Expected hemoglobin minus the patient's current hemoglobin when the patient is presenting to us. Patient's current hemoglobin, right? Okay. This thing into 4. This 4 is a constant, right? This 4 is a constant into 4, right? Into the child's body weight in kilograms, right? This is how we calculate it, right? Okay. Look at this, guys. What is the expected hemoglobin now according to the latest guidelines? 40, right? So let's say we have a, just to make it easier, I will say now the patient's current, usually when it is less than 10 only, we transfuse. But I will say just to make the calculation easier, our expected is 14. I will say our patient's current HB is 10, right? Into 4, let's say he's a 45 kilogram child. 45 kilogram, let's say it's a 13-year-old child, right? Now can someone calculate and tell me? My math is bad. Okay. What is this? 4 into 4 into 45. Guys, any mathematicians here or a calculator? What is the amount? Come on.
720.
720. Okay. 720. Okay. So I trust, who is that in the right? I trust you. Right? So 720. 720 ml of blood needs to be given. But there is a problem. Specifically in our pediatrics, guys, there is a limit per day. Per day, we can only give per day 10 ml per kilogram per day. This is the maximum we can give for one day. 10 ml per kilogram. Right? So if our child is 45 kilograms, for one day, how much of blood can we maximally give him? 450. Right? 10 into 45, no, that I can do. Okay? 450 we have to give. Right? Now, so what is remaining, guys? 720 minus 200 and, right? 270 is remaining, right? 270 remaining. So how can we do this? First day, the patient, we will give them 400 milliliters on day 1. We transfuse 450. On day 2, we transfuse 270, right? Now, what does this tell you, guys? The child has to come to the hospital, stay for 2 days. 2 days. This is actually a good case where the hemoglobin was 10. Usually, we get thalassemic children, hemoglobin 7, hemoglobin 6, 8 sometimes, right? If that is the case, what is happening? The number of days that he needs to stay in the hospital further increases. This is what is the problem here. Quality of life, right? These children have to miss school. Right? I got one patient, guys. The child had to come, right? His HB was drastically low. His HB has drastically dropped. HB was around 7. He had a sports meet in 2 days. Will the parents allow? No. Should the parents allow? No, right? It's difficult. We have to transfer that. We have to keep the child in the hospital, right? So these things you have to think about, right? These children are crying. They're very upset, right? You all have to pay attention to these. Huh? Right? Okay. Did everyone understand this? Right? All good. Give me a thumbs up. Right? Right. Okay. Then, guys, so now one of our mainstays of management, as we said, is blood transfusion. Blood transfusion. If there are blood transfusions being done, there can also be some side effects with this blood transfusion. These also we need to pay attention to. What is one of the main side effects of blood transfusions? What is one of the, sorry?
Iron overload.
Okay, iron overload. We'll come to iron overload. Let me rephrase the question. What is one of the main side effects of taking something external and putting it into your body? Something like blood.
Transfusion reaction.
Yes, also correct. Transfusion reactions, also correct. Transfusion reactions, okay. I'm going for
production reduces.
Okay. Don't overthink. Don't overthink. Right. Look at this. One of the very simple things, right? Infections. This is what I was going for. Okay. Right. Infections. When we have blood transfusion, guys, blood product related infections, right? Now, when we take blood products, we try our best. Laboratories, they will try their best to weed out any bad samples. Right? They will take tiny samples from each packet of blood. They will look under the microscope. They'll do all the testing. But sometimes we can miss, right? The laboratory equipment, they will miss. So hepatitis B, hepatitis virus, HIV, right? These kind of things can be spread, right? So one important thing is infection, guys. So these children also, there are multiple cases, you see, right? Children being infected due to the transfusions. Next thing, yes, what you said was correct, right? Iron overload. Why? In one pack of RBCs, guys, that we are going to give the child, there is about 200 grams of iron, right? So once we start transfusing the child, right? We'll have to transfuse sometimes once a month, depends on the severity, right? Sometimes twice a month, whatever. Eventually, they are going to develop iron overload, right? Now, what does this iron overload do, guys? This iron, right? It will go and deposit in multiple different areas, right? Okay. One of the things I want you to know is skin. It can go and deposit in the skin, right? This iron, guys, getting overloaded and going and depositing in other places. What do we call this? We call this hemochromatosis. So it can go to the skin and give this bronze appearance in the skin. Right now, in our South Asian population, guys, we don't see this bronze color. Okay, right? What we see is a little bit more skin darkening than usual. Okay, right? This is what we see in our South Asian population. Right? Then it can, just like that, it can go to the pancreas. If it goes to the pancreas, guys, what is going to happen? Pancreatic function drops. It can result in diabetes. It can result in diabetes, right? So the skin is bronze and diabetes with pancreas involvement. We call it bronze diabetes, right? So we can see these in these patients. Another thing, it can go to the heart. It can go to the heart and deposit. Iron can deposit in the heart as well, guys. We have dilated cardiomyopathies. Dilated. Now, this is a different chapter, right? I will teach that in another module. Dilated cardiomyopathies, right? Right. Then, guys, it can go to the pituitary gland. Pituitary gland. Right? Now, you all know pituitary. This is our master endocrine gland, right? This guy, if he is involved, right, what can happen? Growth hormone reduces. Growth hormone reduces. FSH-LH reduces, right? Right? FSH-LH will reduce. Like that, guys. Multiple hormonal involvement will be there. So this is another reason why this child is going to get failure to thrive, growth retardation, absent secondary sexual characteristics, right? Multiple things can happen here, right? Okay. Then another one is, guys, this one actually I would want you all to write it on top. Can go to the liver. Iron can start depositing in the liver, right? Here, guys, once iron starts depositing in the liver, right, they are going to come up with hepatomegaly. Hepatomegaly. Now, previously we talked about some reasons where there can be a hepatomegaly from the disease itself, right? Hepatosplenomegaly from the disease pathology itself. Now, what is happening when you are transfusing also? Due to the iron overload, there can also be an added hepatomegaly there as well, right? The hepatomegaly, guys, I want you all to know, when it's occurring due to iron overload, this is more prominent than any of these other manifestations. These other manifestations, you won't usually notice a lot, except for growth retardation. Yes, you will notice. Apart from that, this bronze skin, right, diabetes development, these take time, right? These take time. The hepatomegaly develops quite early. So in these children, pediatric cases, you will see hepatomegaly, right? One of the characteristic findings, okay? Right. Then, guys, now, if all of these are happening, right, what should we do? Should we give blood? If all of these side effects, such a lot of side effects are happening, should we give blood? We have no other option. Right? Blood transfusions must be continued. But what we can do is try to prevent this iron overload. How do we do that? We do iron chelation. Right? Chelation. This is iron chelation. Basically, guys, we are going to give some substances. We talk about what they are. These things they bind to this iron. So let's say they have iron here, and these substances, these medications that we give, they will bind to this iron, right? They form something called ferroxamine, guys. Ferroxamine. And this ferroxamine is easily excreted. Ferroxamine is easily excreted by the kidneys. It is soluble, right? It will be easily excreted, right? So what are these substances that we give? What are these medications that we give? Look at this, guys. Let me erase here a little. Chelation. I will keep the chelation part there. Right? What are these chelators that we use commonly? Right? One of the commonly used chelators, guys. Right? We have an oral form. Right? And we have some subcutaneous forms as well. Right? The oral one, guys. Right? The oral one, we call it oral deferricirox. Right? Deferricirox. Oral deferricirox, right? Deferricirox. In our subcutaneous option, is what we call desferrioxamine, right? Desferrioxamine. Okay. This, for the Sri Lankan students, deferricirox. What's the brand you all have heard? Any known ones? Asunra. Excellent. Asunra, right? Asunra. Right? Desferrioxamine, have you all heard the brand? What's the brand? There is something called Desferal, guys. Desferal, okay? Desferal. Now, from the patients, when you ask, they know these, huh? Patients know what Asunra is, patients know what Desferal is, right? Right. Now, how do we decide what to give to who? Usually, guys, if it's a bigger child, right? If it's a bigger child or adult, right? Child, when we say more than 2 years of age, and if it's an adult, we can go with this oral form, right? But if the child is usually less than 2 years of age, we prefer to go with the subcutaneous form, right? Now, this subcutaneous form, how is it given, guys? There is a pump, right? Now, you all know the insulin infusion pump. This is also very similar, right? this desterioxamine infusion pump is there, right? Usually we have to keep it infusing overnight. So when the child goes to sleep overnight, we put it subcutaneously, and we set up overnight, right? The child will receive the desterioxamine. Okay, is that clear? Right. Then here, guys, this one, the slow infusion, usually we have to give about 8 hours per night. About 8 hours per night needs to be given. Okay, 8 hours per night. And usually, guys, the subcut version, 8 hours per night, usually 5 to 6 days a week, right? So this is a bit of a hassle, right? This is why we almost never give desterioxamine for adults. They will never stick through this, right? They will never stick through this plan. We always want to go with oral, right? Then, guys, there is another one. Just write it down, called deferriprone. Deferriprone. Now, what did we say? One of the side effects of iron overload was that it can go to the heart, right? It can go to the heart and cause cardiomyopathies. This deferriprone has been found out to be the most effective to be used on patients who require transfusions but have cardiomyopathies. They have cardiomyopathies. Okay. Is this clear up to this point? Right? Okay, right. Now, going to a very important part, just listen with all the layers of your cerebral cortex. Okay, look at this, guys. Here, right? Listen carefully, right? Listen carefully. Look at this, guys. We said, right, when there is an iron overload, right? Iron overload, right? What is going to happen? They can come and deposit in the liver. When they deposit in the liver, what is happening? Hepatomegaly. Hepatomegaly, right? Hepatomegaly. Liver gets enlarged, right? And sometimes, guys, later we will talk about that can even progress to cirrhosis. Okay? That can even progress to cirrhosis, right? Hepatomegaly. Right? Then, guys, that is because of the iron overload. So what will happen if we chelate the child or chelate the patient properly? If we chelate them, the hepatomegaly will reduce. Everyone agrees, right? So the hepatomegaly will reduce. Liver size will reduce. Liver size will reduce. Okay, right. Then another principle that we talked about, we said when there is ineffective erythropoiesis, what is going to happen? One thing, the spleen will be stimulated, right? These organs that are not usually producing RBCs, like the spleen, okay, right? Like the spleen will be stimulated to produce more and more RBCs, right? So what is happening is organs like the spleen, they're working out of their job description, we said. So when there is hematopoiesis, mostly what are we talking about? Extramedullary hematopoiesis. What is going to happen? The spleen size increase. Spleen size will increase. Splenomegaly. At the same time, what did we say? There can also be an increased hemolysis, right? When there is hemolysis going on, but hemolysis extravascular hemolysis is going on, that can also cause the spleen to increase its size, right? So splenomegaly is happening, right? Because of all these reasons. Now, if we can stop this extramedullary hematopoiesis, and if we can stop this extravascular hemolysis, what will happen? Splenomegaly will reduce. How do we stop that? By giving transfusions. Why? When we give transfusions, new blood, all that blood needs to be destroyed by the spleen? No, right? So the spleen size will start dropping a little bit, right? And then what about this extramedullary hematopoiesis? When you are giving more and more blood, is the spleen in a need to produce more and more RBCs? Not really. So what is happening? If we give transfusions, the spleen size will reduce little by little. Okay, right? Okay. Now, what is the importance here, guys? Look at this. If you see chelation, right? Let me write it here. Chelation, right, is related to the size of the liver. You all can color this L in a big, Chelation relates to the size of the liver, right? Transfusions, right? The S big, right? Transfusions, they relate to the size of the spleen. Right? Everyone agrees with this based on what we talked about, right? All of this. Give me a thumbs up. I just want to make sure you all are not confused before we move forward. All good. Thumbs up. Okay. Atif, good. Dinita, understood. All good. Yeah. Okay. Excellent. Shabib, all good. Who else is here? Right. Himesh, yeah, okay. Abash, okay. Right. Okay. Look at this, guys. If this is the case, if we are, now I'm telling you, now you're telling, if we are getting a patient with isolated hepatomegaly, the child, when you examine the abdomen, isolated hepatomegaly, right? But the spleen is normal. What does this tell you, guys? The chelation has not been done properly, but the transfusion has been done well, right? Transfusion has been done well. So what is this child? A poorly chelated but adequately transfused case of beta thalassemia major. Okay, everyone agrees, right? Okay. Then what if we also get a patient with massive hepatosplenomegaly both? Come on, massive hepatosplenomegaly. What is it? Huh?
Poorly transfused and chelated.
Poorly transfused, poorly chelated, beta thalassemia major. Did everyone understand it? Now, this is how we give our diagnosis, especially in a short case, pediatric short case, when you are examining the patient, right? When you see hepatosplenomegaly or when you see isolated hepatomegaly, isolated splenomegaly, and in a thalassemia patient, this is how you have to give your diagnosis. Okay, right? Did everyone understand this? This is a little bit, I want you all to read this through again after the class or within the next week. A little bit, right? Confusing sometimes. So just go through this once or twice. Okay, right? Okay. Once that is done, guys, then we go to the other steps of the management, right? We are still in the management. Another thing we want to do in the management is, guys, diet, right? This is number 3, right? Diet. What are we going to do to the diet of a thalassemic patient? Look at this, guys. What do we want to prevent? Iron overload. So what should we do? Sorry, you can see me clearly. Yeah, all good. Okay. What do we want to do? We want to prevent the patient from taking iron, right? That is basically what we want to do. So what do we say, right? How do we advise the patient? Now, imagine, now these managements, guys, now I know we are talking about adult medicine, but I want to focus more on pediatrics because this thalassemia is a hot topic there, right? Medicine, you will rarely get a case, right? Especially for your exams also. Okay. Now, in pediatrics, if the patient, if the child is coming with the mom, right? Now you have diagnosed thalassemia. What are you going to tell the mom regarding the diet? What can you tell? What can we tell? Come on. Don't give the child meat, right? Don't give the child meat. Don't give the child green leafy vegetable. Guys, it's okay to say all of that, right? But there is a way to say. Okay. Now what will happen? If you tell the parent, don't give the child meat, don't give the, I think I had this class, I taught thalassemia, guys, about 3 years back, right? Back then also, when I met a patient, I told that story back then also. There was one child coming in, his complaint, the child was thalassemic, the full diagnosis and everything on management came for transfusions. He was crying and his complaint, like when you talk to the child, what is he saying? Everyone's eating hamburgers, I can't eat hamburger, right? That was the complaint of the child, right? So when you ask the parent, when you ask the mother, mother is not giving any meat to the child. Why? That is how she's been advised, right? Don't give meat to the child. So you have to make sure to educate properly, guys, right? Educate properly. You say, okay, there is a problem in this child with iron overload, right? So we want to try and minimize. But at the same time, there is something called the child's quality of life. You have to explain that also to the mother, right? You have to tell them, right? You can't stop everything completely. Otherwise, the child will go into depression and there will be other issues there, right? So every now and then it's okay. Right? But when the child has to undergo a transfusion, maybe for the next 1 or 2 weeks, just reduce the meat consumption a little, right? Reduce spinach and stuff, right? Right? Not 100%. Okay. Make sure you say that. Okay. Because it has to be a balance. And then there's this tea and toast diet, guys. We'll talk about this in iron deficiency anemia. I don't know if I've taught this to you all before. Tarinder, you have joined that session, right? Tea and toast diet. You usually give this plain tea because this plain tea, guys, it has these tannins and these phytates, right? And that reduces iron absorption. How it does that exactly, will discuss in another class. Huh? Very interesting mechanism, right? Okay. So you have to make sure this diet control is there, right? Reduce the iron intake, right? But not 100%. Just reduce, right? Okay. Then, guys, the next thing, there is a place for splenectomy. Why will we remove the spleen, guys? Why we remove the spleen is, guys, in some patients, not in all, in some thalassemia major patients, right? the spleen doesn't resolve back to its normal size even with adequate transfusions, right? Even with adequate transfusions, the spleen persists, right, in that size, right? So in those kind of cases, we can do splenectomy, guys. When you do the splenectomy, what happens? The need for transfusions reduces, right? So the frequency of transfusions can be reduced, right, by doing a splenectomy. Y'all can hear me? I don't know what is going on today, guys, right? It's like, can y'all hear me? Yeah, Tarinda? Yeah, okay, y'all can hear me. Okay, right. Right. Anyways, right, let's go on. Then the other thing, next thing I want you all to know. Here, guys, when we do a splenectomy, what are the problems? True, it's an advantage. We can reduce the need for transfusion. If we reduce the need for transfusion, we can also indirectly reduce the need for chelation, right? You all understand, right? So, what are the problems with splenectomy? What are the problems?
Recurrent infections.
Recurrent infections. Good. Why?
Because the spleen destroys the capsulated organism
How? Good. Excellent. Good. How?
by activating the complement pathway.
Yes. What is one of the... yes, you're correct. Any specific molecules that you have heard about that the spleen produces to do that job? Good. I'm just asking, since you're advanced guys. Opsonins, right? There are these stuff called opsonins, guys, right? The spleen produces these opsonins, right? Good, good. You all are good, right? So what these opsonins do is, guys, they coat. Let's say there are pathogenic organisms, specifically these ones we call capsulated organisms. They have a very thick capsule, right? We'll talk about that later. They come and coat these opsonins. They come and coat these capsulated organisms, right? So that they become more attractive to macrophages, right? They become attractive to macrophages. Then there are some other processes, guys. Yes, Tarinda, you're correct. There is something called a membrane attack complex being formed, right? We'll talk about all of that in different class, right? So what is going to happen when you do the splenectomy, opsonins are not there. Therefore, what happens? These capsulated organisms, the patient becomes very, at a high risk of acquiring these infections by capsulated organisms, right? Okay. Right. Now, when that is the case, guys, what are these capsulated organisms that I want you all to know? One is Haemophilus influenza B, right? These are the important ones, right? Then you have our pneumococcal species, right? And our meningococcal species, right? So what can we do to prevent these, guys? If we are doing a splenectomy for the child, right, we have to vaccinate the child against these, right? Now, these vaccines, guys, right, they are not in our normal EPI schedule, right? These are out of the normal EPI schedule, right? So we give these vaccines to make sure the child is protected against these pneumococcal, meningococcal, these species, right? Okay. So in your pediatric short cases, in your examinations of the patient, you have to make sure if you're getting a child with thalassemia, if you're suspecting a child with thalassemia, you have to check for the splenectomy scar. Okay, don't miss the splenectomy scar. Okay, right. Then the next thing, guys, the spleen. What is another? How can I ask this? What is another function of the spleen with regards to platelets? Normal physiology. What do you all know?
It stores.
Excellent. Spleen has a storage function when we consider platelets, right? Right. There's what we call splenic sequestration in certain conditions. Right? We'll talk about those later. The splenectomy has a platelet storage function. Now, if you destroy or if you remove the spleen, what is going to happen? Platelets are going to start coming into the circulation. When there is an excess of platelets in the circulation, what is going to happen? Right? We are going to have high thrombogenicity, right? So these clot formations and all can happen, right? So this becomes mainly a problem, guys, towards older age, right? When we are having risks with ischemic heart disease, right? Strokes, right? More towards the older age populations, right? That is when the issues start coming up. Okay. Right. Then, apart from that, there's what we call the curative option, guys. For thalassemia, we only have one actually. The curative option is bone marrow transplant. Right? The bone marrow transplant, guys, it is quite effective. The 3-year mortality is usually, they say, less than 5%. But the problem is, it's very difficult. to find the HLA. There is something called the HLA match, guys. Very difficult to find HLA matched transplant, a donor, right? HLA matched donor, it's very difficult to find, right? And also, guys, bone marrow transplant, you all should know if the child is currently having iron overload or liver damage. We said when there's hepatomegaly, later with the iron overload, it can progress to cirrhosis. So if the child is already having cirrhosis, these bone marrow transplants, we don't usually recommend doing in those cases because the mortality rate is still high, right? Still high, right? So we don't want to risk it, right? So we don't usually do it. Is everyone clear about this after this? Right? This is our basic thalassemia. Basic, right? This is the core concepts that I want you all to know. Now, if you all understand this, the next section is very easy, right? The clinical skills part, CS part. Tell me this. Do you all want a break or not? Are you all tired? How is it? How is it going? Huh? Come on. Give me some messages in the chat. Do you all want a break? Huh? Are you all going to fall down? Right? 5-minute break or 10-minute break? What is happening? Tell me, guys, are you all tired? Or can go on? Now, the CS part, it won't be like this. Huh? It will be just a discussion with you all. 7-minute break. Okay. Right. Okay. So let's take a 10-minute break. Right. Come back. Right. We'll discuss the clinical skills portion. Okay. Right.
Can I ask a question? What were if the patient has cirrhosis, and what was the other indication? Like, we don't usually go for bone marrow transplantation. So I think, yeah, muted.
Sorry. Can you hear me? Guys? Yeah. Okay. Basically, liver damage, cirrhosis, together with other features of severe iron overload. So if they have cardiomyopathies, right? If they have what we call the bronze diabetes, right? The pancreas involvement, right? These kind of manifestations, guys, their risk becomes, so you all know we do something called the risk benefit analysis of doing a procedure, right? If they have those features of severe iron overload over a long period of time, we usually, the prognosis even after doing a bone marrow transplant is poor, right? That is why we tend to not recommend that. Here.
Okay, thank you.
Right. The 10-minute break, huh? Right. Is everyone back? 10-minute break also. All good. Himesh, you're currently in Sri Lanka or are you abroad?
Abroad,
Okay.
China.
Good. What's the weather like? Cold?
It's cold.
You're lucky, lucky. Count your blessings. Right. Okay, guys, turn your cameras on, right? See some faces. Right, let me share this.
I have a question.
Yes.
After splenomegaly, why does the need for blood transfusion decrease after splenomegaly?
Not after splenomegaly, after
Splenectomy,
splenectomy.
sorry.
Okay. So,
Yeah, so why does the blood transfusion need decrease after splenectomy?
because, so now what was the problem, guys? Why were we doing blood transfusions in the first place? There was abnormal erythropoiesis, right? And the spleen was getting hyperfunctional, right? That's why the spleen started increasing in size and size and size and size, right? So to reduce the spleen size, we are giving them transfusions, right? So when you give transfusions, this is why we said transfusions are related with the spleen size. So whenever we give transfusions, the spleen size will reduce. So when we remove the spleen, right? Is there a need for us to keep reducing the spleen size? No, right? Okay, right? Understood.
Okay.
Right. Okay, let me share the screen. So now, guys, now I want you all to unmute and talk with me. This part, the CS part, the clinical skills part, right? Give me a second. Where is this? Can you all see the screen, guys? No, not yet. Can you see it now? Yeah? Right, excellent. Great. Guys, is part of the right corner of the screen that you all can see, is it cut? Can you all see what I'm writing right now? Can you all see this? Okay, right, so it's not cut. Okay, good. So let's go ahead, right? With our class. So, clinical skills, right? Here, guys, mainly we are going to focus on pediatrics, right? Because this is what is important here, right? When we come to the history taking, right? So usually pediatric cases, you are going to ask the history from the mother, right? What is one of the, yes, true, I have put the symptom analysis here. Before that, guys, even before that, one of the most important things I want you all to ask from the patient, right? Ask the patient's mother is their location, the place of living, right? This is very important. Place of living, why is it important, guys? In Sri Lanka, and I even confirmed this with one of my friends from India, they said, Eastern India, there is a high occurrence of thalassemia, right? Same in Sri Lanka, guys. We have these areas, these Anuradhapura, Polonnaruwa side areas, right? There is a higher prevalence of this thalassemia, right? Because the patient is not going to come and tell you, doctor, I have thalassemia, start me on medication, right? No, you are going to find little bits of clues from whatever information you can to try and come to a diagnosis of thalassemia. So the place of living is important. Place of living is important. Second thing is, guys, you have to confirm the age of the patient. Why? Specifically, if the child is less than 6 months old, right? Less than 6 months old, but coming with some features, right? Of anemia, right? Shortness of breath, whatever, failure to thrive, whatever. If it is less than 6 months of age and he's coming with such symptoms, it is unlikely to be thalassemia, because we talked about thalassemia manifestations start coming after the age of 6 months, right? Okay. So age also needs to be confirmed. Okay. Right. Then we come to the symptom analysis. So what are we going to ask about, guys? Right. Now, usually, the patient will present with something like the child's hemoglobin is low, or they will come and say they came for transfusions, right? Whatever. You have to ask about the onset, the first episode, when they were first noticed this, right? Is this the first time they are coming to the hospital, or have they come to the hospital before and have they already been given a diagnosis of thalassemia? This you must ask, right? Okay. Right. And you can ask the onset of the symptoms. Was it after the age of 6 months? Yes, as we confirmed with the age, right? And then you must ask, guys, these, if they are a thalassemic patient, 99% of them will know their last HB, because they are constantly coming to the hospital. They are coming for transfusions. Every time they come for a transfusion, we will do a blood test. We will check the hemoglobin, right? So you ask their last hemoglobin levels to see if they know it, right? If they know it, good, right? And you can also ask, have you previously been diagnosed with thalassemia? Right? They know this word called thalassemia. Okay. Right. Then you ask about the current management, guys. Right? You ask about the current management. So you have to ask, if it is, you're asking the history from the mother, was the child on transfusions before? Has the child ever been started on transfusions? Why do we want to ask this? Like, we know if the child's spleen is big, right? That means what? Inadequately or poorly transfused. He's being poorly transfused. He's not being transfused adequately, right? That is important. Then you can also ask about the chelation. Is the child on iron chelation, right? Again, why? Because of the hepatomegaly. Here, guys, what I want you all to understand is, for the chelation, we usually start the child on chelation, right? After about 10 transfusions, right? After about 10 blood transfusions, that is when the child usually requires chelation, right? Okay, right? That is an important point there. Then the next thing, any facial changes, any abdominal swelling, any side effect of the transfusion. Yes, you have to ask all of these, any infections, any recent infections that the child has got, right? Have they been given, you can ask about, have they done splenectomy? In the history, you can ask, have they done a splenectomy? And if they have done a splenectomy, have they been given the vaccines? Have they been given the prophylactic vaccines, right? All of these questions you must ask. This is again related to the next one as well, about the vaccination history. Here you can ask that. Here, guys, also you must ask, right? As with our routine questions, have all the epischedule vaccines been given, right? EPI schedule vaccines also you must ask, okay? Have they been given, right? And has the child, usually, guys, here, I want you all to know, now we are starting the child on transfusions now. Before we start the child on transfusions, we would want to definitely make sure that the child has received vaccines for hepatitis, right? We want to try and prevent that, okay? So you have to ask about that. And if they have received hepatitis, what should you do to confirm that the vaccine has worked? You have to check the antibody levels of the hepatitis. So you have to check the antibody levels before starting transfusion as well, right? So hepatitis vaccine plus the antibody level check, right? Okay, right. Then coming to the family history, right? We have to ask about, yes, consanguinity, because this is an autosomal recessive condition. So consanguinity is one of the major risk factors. So you have to ask, is the mother and the husband or the child's father related? Okay, right? If the child's father is someone else, then no need to ask. Okay, then that's probably a different condition, not thalassemia, right? Anyway, then any affected first degree family members. Yes, you can ask about any siblings. Does this child have any other siblings? And is the sibling also having similar manifestations, right? So maybe the sibling also has, right? Because we did the cross, we saw the chances, right? That the next child can also be having, right? Then, guys, again, the social history, the birthplace of the mother and father, you can ask if they're in these high risk zones, right? If they're in this high risk zone, and the education about the disease. This is what we talked about, right? About the dietary changes. You have to ask, guys, do you, like, let's say in the history taking, you find out that this is a consanguineous marriage, right? What should you ask first? Do you know that consanguinity is one of the causes for this child's condition, right? You should find out if the parents know. Sometimes they don't know, right? That consanguinity. So, and they keep having children. They keep having more and more children, and many thalassemic patient children, right? So you have to find out if they know that consanguinity is a cause, right? And you have to ask, do you know the chances of your next child having thalassemia as well, right? You have to ask about these kind of questions. And then, guys, if it is a consanguineous marriage and if it is confirmed that the child is having thalassemia, right, they are likely heterozygous carriers. The mother and the father are likely heterozygous carriers. You can do the genetic testing as well. But what should you advise on? Contraception. You must advise about contraception. Okay? Contraception. Right? And then you can also ask about the medications and the transfusions and the side effects of those. Are they aware? Right? All of these comes under education. Right? Are you aware of the side effects of the transfusions? How you can control the iron overload, the chelation? Right? How often should you give it? All of these you should ask to see if the parents know. Then you ask also some education related points regarding the child's diet. Okay? Reduce diet like I talked before, right? Not 100% reduction, but as much as possible. Okay? Right? And then again, you also have to pay a little bit of attention to the child's social life as well, guys. The child's school, education side also, you have to ask a few questions, right? How is the child doing in school, right? Is he all right with his friends? These kind of questions you have to ask in your social history, right? After that, guys, we come to this discussion points, right? These are now in your Viva exams. These are what the examiners like to ask you, right? So one of the questions they like to ask is this, what we talked about at the start. Why do these children develop manifestation at the 6 months of age, right? This one now you all understand the mechanism undergoing, so you all can explain, right? How would you classify anemia in a thalassemic child? Now this one I didn't teach you all guys. How do you think we can classify? Based on what? Based on what can we classify anemia in a thalassemic child? How do we classify anemia in any condition, guys? Not just thalassemia. Any condition, how do we classify anemia?
Depending on the hemoglobin level.
Excellent. Depending on the hemoglobin. Depending on the hemoglobin. So here what we are looking for is, guys, let me write it here, right? We check the hemoglobin. Usually if the hemoglobin is greater than 10, right? This is usually a mild case, guys. This is a mild case of thalassemia, right? Usually the thalassemia traits, the minors and the traits, right? Then we can have another one where HP is less than 7. These are our severe cases. These are our majors, right? Thalassemia, beta thalassemia majors. Then finally, right, HB of 7 to 10 is our moderate one. So this can be a properly treated major, right? Or this can be a thalassemia intermedia, right? So that one, guys, that is a clinical judgment. That is a clinical diagnosis. We have to do further testing, right? We cannot immediately say if the HB is between 7 and 10, we cannot say this is thalassemia intermedia. No, right? It can be a major that has been properly treated, right? Right? Okay. That just know that is moderate. Can be intermedia, can be a properly treated major. Right? Then, what are the examination findings? What are the examination findings you're going to look for? Let's talk about gastrointestinal examination. Come on. GI system examination. Physical examination, huh? What are you going to look for?
Hepatosplenomegaly.
Hepatosplenomegaly. That is the first thing to do. Then, cardiovascular system. What do you want to look for? Cardiovascular system.
Cardiomegaly.
You want to, how do you assess for cardiomegaly? Good. How do you assess for cardiomegaly?
Look at the apex.
Yeah, look at the apex. Check where the apex is. Check if it has shifted, right? There can be dilated cardiomyopathies. We talked about when there is iron overload, right? Okay, so look for the cardiac apex, right? Then, another thing, guys, you all want to check the child's growth. Now, in Sri Lanka, we have this child health developmental, CHDR, right? You all will learn this for community medicine, right? Favorite subject of mine, right? Okay, I really hope you all understand sarcasm, okay? Right? Okay. Anyway, CHDR, right? Sorry. Right? You all have to mark the child's development, right? Height, age, weight, all of this, right? And we plot it in graphs, right? Okay. Very interesting subject. Anyway, so we have to check the child's growth related to his age, right? Growth related to the age. What are we looking for? We are looking for failure to thrive. There are in that CHDR, guys, once you plot them, you all can see the green zones, the red zones, orange zones, right? It's there, right? Right? Go through that. Okay. Basically what you are looking for is failure to thrive, right? Now, guys, community medicine, right? I'm not blaming or anything, right? It's a subject with opportunities in health related other things. If you all want to do health related other work, right? Rather than just working in the clinical setup, if you all have masters in your community medicine and all, very helpful. You all can work at WHO, right? Multiple opportunities are there. I know the subject is problematic, but there are multiple opportunities if you all have masters or PhDs in community medicine. Okay. Anyway, right. The next thing, where are we? The next thing, guys, so we check the cardiovascular system, we check the child's growth, right? And you can also assess the genitalia, guys, because we want to look for secondary sexual characteristics development, right? These kind of things we want to look for, right? Then, here, guys, now the investigations we have talked about. One thing, guys, I didn't mention in our investigations, we talked about how we are going to do the blood picture. We want to start off with the full blood count, right? Where we are looking for the hemoglobin concentration. At the same time, we can look for these MCH, mean corpuscular hemoglobin, right? Mean corpuscular hemoglobin concentration, MCHC, right? We can check the reticulocyte distribution. We talked about all of these, right? These now you're familiar with. And we talked about the iron panels, guys. If you all remember, iron panels, I specifically talked about thalassemia trait, right? And what did we say? Iron panels in thalassemia trait, right? Iron panels in thalassemia trait is normal. Iron panel is normal. So we take the serum iron, right? We have the serum ferritin, right? Then we talked about the total iron binding capacity, and we talked about the percentage saturation. This is for the trait, it was all normal, right? It was all normal. Now, guys, if a thalassemia major child is coming, major, beta thalassemia major, what will we see? Here, guys, why I didn't teach it then was because there are some factors that will affect the iron panel in a thalassemia major child. For example, if the child is already receiving transfusions, right? If the child is already receiving transfusions, let's say he has received more than 10 transfusions, usually this child is nearing what? Iron overload. This is why we said usually after about 10 transfusions, we need to check the iron panel, and we will usually see iron overload. That's when we start chelating the child. Okay. So usually in a child with thalassemia major, right, specifically if they are undergoing iron blood transfusions, you will see iron overload. So the serum iron and the serum ferritin will be seen high if they are undergoing transfusions, right? And again, if their hemolysis is severe also, because we said in thalassemia majors, they are having severe anemic manifestations, their hemolysis is severe. Then also you can see a little bit of increase in the serum iron and the serum ferritin. Okay, right? Then, what do you think about the total iron binding capacity and the percentage saturation in thalassemia majors? What was the total iron binding capacity dependent upon, guys? Now, these terms, everything we've discussed in our iron profile video, if you all haven't watched, just go watch that, right? Soon after the lecture, even it's fine, right? What is this total iron binding capacity? It's dependent on our transferring. It's dependent on transferring. Is there a problem in transferrin production in thalassemia majors? Right? Usually no. Usually no. So usually this is normal. But, important but, there's a big but here, right? What is important here, right? If the patient is on transfusions and now more than 10 transfusions and you're chelating them, right? What did we say, guys? Before we start this chelation, they are going to have features of iron overload. One prominent feature was what? Iron goes to the liver and gives hepatomegaly. Hepatomegaly, right? Everyone agrees? If there is hepatomegaly, what did we say? If the patient was not properly managed, if they were not regularly chelated, what can happen, guys? They can progress to cirrhosis. The iron overload can continue and they can progress to cirrhosis. If they're having cirrhosis, what can happen to the protein production by the liver? Proteins like transferrin can start dropping. Then what can happen to total iron binding capacity? It can reduce, right? Now, these are some a little bit complex, right? But I hope you all are understanding why this happens. Okay. Then the percentage saturation, again, the same, guys, right? If the transferrin is dropping, we know, right? In sometimes, so if there is no problem with liver cirrhosis or anything, it can be normal. But if the transferrin is dropping, there can again be a drop in the percentage saturation as well. I hope you all understand these concepts. Okay. This is thalassemia major iron panels. Okay. Right. Right. Then, look at this. Where are we? So we'll come again for our management plan, right? What are we going to do, guys? We are going to counsel and advise. Counsel and advise whom? Right? The parents, right? In the pediatric trial, the parents. You don't want to counsel the child, no, they won't understand anything. Right? Counsel the parents. So you're going to talk about all these consanguinity, all these diet, right? All of that. And you have to ask about, are they planning for future pregnancies, right? If that is the case, right, you have to advise them on that. There should be a risk assessment of what are the chances of the next child developing, right? Things like that. Then mainstay of management, we've already talked about, guys, all of these 200 grams of blood. We've talked about all of this. So HB, guys, usually we said if the HB is less than 10, we usually transfuse the child, right? This is our pre-transfusional HB. That's why I put it as 9. Usually we say if it is less than 10, we need to transfuse. And the post-transfusional target nowadays, right, we are using 14, right? HB target. Okay. Right. Then what is our choice of blood, guys? Actually, I haven't mentioned it here. Choice of blood. What blood are we going to give? Right? You all can write it down. Huh? Choice of blood, guys, write it down. Leukocyte depleted, right? Leukocyte depleted. Leukocyte depleted. Washed, right? Packed red cells. Now, What does this mean? Don't memorize. I'm so against, you all know me. What does this mean, guys? What do these words mean? Leukocyte depleted, everyone understands now, right? What is leukocyte depleted? We have removed the leukocytes. We have removed the WBC cells as much as, none of these guys, we cannot do it 100%. Okay, we do it as much as we can, right? So as much as we can, we've removed the WBCs. Why are we removing the WBCs? Because WBCs, these are cells, right? When foreign cells come to our body, there is a risk of reactions, right? Transfusion related reactions, adverse allergic reactions. So why are we reducing the leukocytes? To reduce the risk of transfusion reactions. Okay, fine. What is washed? How are you going to wash blood? Huh? How are you going to wash blood? Right? What is this wash, guys? This is not just washing, right? What they're saying here is we are reducing some plasma proteins, right? We are reducing, washed means removal of some of the plasma proteins. Why are we doing this? Again, plasma proteins, these are also proteins. They also tend to act as antigens when given from a foreign source, right? In your body, they will be recognized as antigens and they will be attacked against, right? So washed means what? Removal of some plasma proteins. Okay. Then packed red cells. What are these packed red cells? You want to put red cells in a pack? Yes, that is exactly what it means. What we mean by packed red cells is, guys, we are removing some of the water component. What do we mean by water? We are removing some of the plasma component, right? The blood plasma. So we are separating the RBCs from the plasma and we are giving the patient plasma itself. Why do we we are giving the patient RBCs alone? Why do we want to remove some of the plasma, guys? Plasma, you all know, it has a lot of platelets, it has a lot of clotting factors and all of these things, right? So we want to get rid of those as much as possible, right? Because if you give it to the patient, there can be hypercoagulability, right? And clotting risk can be high. Okay. So this is our choice of blood, guys, right? This, the very famous question, huh? Remember this: leukocyte depleted, washed, and packed red cells, right? Packed red cells. Okay. Right. Okay. Then, yes, you have to look for features of iron overload, right? We talked about all the features, right? No need to discuss again. And the management of the iron overload, guys, see, this is the one we talked about. Serum ferritin is more than 1,000 micrograms per liter. This usually happens, guys, after about 10 transfusions of blood, right? After about 10 transfusions of blood, if you do an iron panel in the child or the patient, you will see serum ferritin more than 1,000. Now, serum ferritin being more than 1,000 is an indication for us to start chelation, right? And the choice of chelator will be based on the age. We talked about this in child. If they're less than 2, we are going to go with the subcut, right? Dysferrioxamine. If they are more than 2, bigger children and adults also, we can go with oral, per oral, right? Deferis-Sirox, right? Then these other considerations, these are some extra points for you all, guys. If you all can remember, it's good, right? This, if the child has good renal function, now you all know the child can have iron overload. Iron can also go to the kidneys, guys. Iron can also go to the kidneys and cause renal function abnormalities as well. This is why in thalassemia patients, when they come for their routine visits, true, we do the full blood count. We also do a liver profile and we do a renal profile. We check the serum creatinine, blood urea nitrogen, and the serum electrolytes. This is our renal profile. We have to do a renal profile as well. If the child has good renal function, guys, right, this Deferis-Sirox, right, has a higher efficacy, right, in terms of management. It is more effective than Dysferrioxamine, right? So that is a clinical judgment, guys. Usually we won't get to make these decisions. These will come from higher above, right? Okay, so nothing too much to worry, but just know. If the chelation, now let's say you have put the child on oral Deferis-Sirox, right? Child is more than 2 years of age. Let's say 10-year-old child. He is on oral medication. Right? And you check, when they come for the next transfusion, you can check, right, their iron panels. And if the chelation is inadequate, you can put them on subcut as well, right? Even though they are more than 2 years of age, there is a place, right? And then evidence of cardiac involvement. We said, guys, we mentioned this deferri-prone, just remember, right? Then here, guys, this is important for Dysferrioxamine. We said, right, usually 8 to 10 hours per day. We said when the child goes to sleep at night, we will put them on this subcut Dysferrioxamine, right? So that throughout the night, it will be pumping using this Dysferrioxamine infusion pump. And we need it for 5 to 6 days per week. This is what we call adequate chelation, right? So when you're taking the history from the mother, right? If this child is already on subcut infusion, you must ask, how many hours per day do you usually put the child on the chelation? how many days per week, right? Now, if the patient says, doctor, before sleeping around 2 hours and then maybe around 2 to 3 days a week, what is this? This comes to what we call the problem list. In our history taking, guys, there is something called the problem list, right? So this becomes a problem. This child is not being adequately chelated, right? Okay. So you have to ask these questions, right? Then, guys, the side effects of the subcut infusions, obviously there can be local pain and tenderness. Sometimes if it is not injected, the needle is not placed properly, there can be infections and related abscess formations, right? Abscesses, high swinging fever, right? Fever with chills and rigors, these kind of things can be there. Hypersensitivity reactions can be there, yes, for the dysferrioxamine as well. Not very common, not very common. And this Yersinia infections, guys, this is because of this. Yersinia is an iron-loving species, right? This guy is an iron-loving species, right? So no need to know the exact mechanisms there, but there is a risk, right? And then visual and hearing impairments can also be there, right? Then, right, follow up. What are we going to do in the follow-up, guys? What are you going to look for in the follow-up? One thing, yes, the advice on the supplements and the diet is to the folic acid and the diet, how to modify the diet. We've talked about this, right? Assess the child's growth and development and the size of the liver and the spleen. We've talked about that also. So we've talked about this adequately transfused but poorly chelated, right? You all understand all of this now, right? Just give me a thumbs up, guys. I'm going a little bit fast because we've discussed all of this, huh? Right? Okay, excellent, excellent. Right. Who else is here? Let me see some new faces. Right. Dinita, all good? Yeah. Abash, all good? Yeah. Okay, excellent. Right, right. Okay, then, where are we? Follow-up investigations. What do we want to do for our follow-up investigations, guys? Just try to guess and just tell me. What do you want to look for in when the patient comes for follow-up? Liver function test. Excellent, excellent. Anything else? So, liver function test, what are we looking for, Tarinda? What are the... Yeah, okay. Liver function. AST, ALT, right? AST, ALT, and we can check alkaline phosphatase as well, ALT as well. Yeah. Renal function test, what are we looking for? What are we looking for?
Creatinine, blood urea nitrogen, serum electrolyte.
Right, excellent. Right. Then anything else? Anything else?
Echo.
Excellent. We can do echo as well, specifically if we are suspecting dilated cardiomyopathy, guys, and the child is showing these manifestations, right? Especially heart failure and related manifestations. Okay. So we can do a 2D echo as well. 2D echo as well. Right. Apart from that, guys, we have to do iron panels at least every 3 to 4 months. In these children, you must do an iron panel, right? You must do the iron panel to see if he's being adequately chelated. Specifically, we want to look at the serum ferritin. Serum ferritin. Why? Ferritin, we said, is a good indicator of our iron stores, right? Iron stores. So we discussed all of that. Apart from that, if there are hormonal related issues, right? For example, iron can go and infiltrate the thyroid, right? So you can check these TSH and the T4, T3, you can check these as well. Those depend on the child's manifestation, right? You don't check everyone's TSH, T4, T3. No, not necessary, right? Depending on the child's manifestations, these other investigations you can do in suspicion of iron going and depositing in those areas. Okay. Right. Right. Then the next step, consider splenectomy if necessary, right? This is evidence of hypersplenism. Even with this, just note, guys, hypersplenism, even with adequate transfusions, right? Usually with adequate transfusions, the spleen will come back to normal, right? But if the hypersplenism continues, it's persistent, then we can consider splenectomy, right? Okay. And rapid drops in hemoglobin, right? Massive splenomegaly that does not go back to normal size. These kind of things are indications, right? You all can write those down. Now, what are the other treatment modes? This is again a little bit extra for you all, guys, right? There are some other treatment modes that we are now trying, right? This gene therapy and stem cell transplantation. Again, the stem cell transplantation is our bone marrow, basically. We're talking about one thing very expensive, and we said HLH match very difficult to find. Even in siblings, guys, even brother and sister, HLH match won't be there exactly, right? Most of the time, right? It's very difficult to find, right? Okay, sometimes won't be there. Then gene therapy is there, guys. So this is, right, we find the defective. So these are point mutations, right? What we are doing is we are going to splice, right? We use these bacteriophages, right? Not necessary to know, right? Basically what we are doing at the gene level, we are trying to correct these problems. Okay. hydroxyurea, right? This one, guys, this one, I don't want you all, this is a little bit complex. Just know, especially we like to use this in thalassemia intermedia, guys. Thalassemia intermedia, right? What this hydroxyurea can do is it can increase the fetal hemoglobin, HbF, right? Now, why do we want to increase the HbF in a patient with beta thalassemia, right? A little bit complex, right? Let's not discuss into that depth, but just know, right? There is a place, right? Okay. Actually, guys, okay, if anyone's interested after the class, just drop me a message. Okay, right? A little bit complex mechanisms, right? I can share some research articles as well, right? But what they have found out is it can reduce the need for transfusion, right? Transfusion. In thalassemia intermedia. Thalassemia intermedia is a what type of transfusion dependency? Thalassemia intermedia? Come on. Non-transfusion dependent, right? Non-transfusion dependent. Excellent. Then, what are the problems with splenectomy? This we have already discussed, guys. You all know, right? One thing, platelets increase. So thrombogenicity increases, right? We talked about frequent severe infections from the capsulated organisms, right? Pneumococcal, meningococcal, and Haemophilus influenza B, right? So often, guys, when you do a splenectomy, you have to, before doing the splenectomy, you have to vaccinate the patient, right? Also, they usually will require lifelong penicillin prophylaxis, right? Sorry about my handwriting, guys. Yeah, I'm holding the iPad in my hand. Okay, right? Okay, then, what are the infections that are possible? Yes, we've talked about this, hepatitis B, right? Hepatitis C, not S, right? Hepatitis B or hepatitis C, right? HIV, cytomegalovirus, yes, right? All of these are possible, right? Then, what are the advices you want to give? Advices to the mother or the patient if it is an adult. What are the advices you want to give, right? Again, the same stuff, guys, right? These questions, they like to ask. That's why I've put it here in your Viva discussions. They like to ask these guys, right? So in your long case, for Sri Lankan students, for long case, you all have 10 minutes. That is the slowest 10 minutes you will experience, right? Ever, right? Right? That's a lot of time to ask a lot of questions. Okay. So practice with your friends, right? Okay. For an already diagnosed child, right? Genetic counseling, the parent, genetic counseling, screening, right? If they're planning to have further children, right? And this chorionic villus sampling also can be done, guys, antenatally, chorionic villus sampling also can be done, right? Then hepatitis vaccination must be complete. We talked about this, and antibodies must be checked, right? And advice on any psychosocial impact. This is what we talked about, right? The parents must not be overprotective of the child and stop everything, right? We don't want to keep the child locked in a room, right? That is not the goal here, right? There should be a balance, right? And then discourage consanguineous marriages, yes. So these are community medicine stuff, right? So you all can go through, right? Mass screening, right? All of these can be done. Now, this related emergencies, guys, I want to ask, I put it here, right? Because these are quite important. Look at this. Let's say we have, read the question, 13-year-old thalassemic child at the clinic for follow-up. Hemoglobin is 9. So that means rightfully blood transfusions have been commenced. While on transfusion, he develops sudden shortness of breath. Examination reveals heart rate increased, right? Increased heart rate and persistent cough. Blood pressure is 90/60. First, tell me, what is the diagnosis here, guys? What is the diagnosis?
Anaphylactic.
Right.
Transfusion-related reaction.
Yes, transfusion reaction, yes. More prominently here, guys. Okay, let me add some manifestations here. I think it'll be better. On further examination, you auscultate the child and you notice bibasal crepitations, right? And you notice, yeah, that's enough. Bibasal crepitations are there. Now, what is your diagnosis?
Pulmonary edema.
Pulmonary edema. How does pulmonary edema happen? Here. So what are we having? Shortness of breath, pulmonary edema, heart rate increase, tachycardia, right? And blood pressure dropping. What is this? What is this?
Hypovolemic shock.
Yes, this is, guys, true, it's shock, but this is acute heart failure. When we are giving blood this is a known side effect of blood transfusions. What is happening when you are giving blood transfusions, guys, especially if it is too rapid, right? The child can go into sudden volume overload, right? What we call the ECBV increases, effective circulating blood volume increases, right? Therefore, the child goes into fluid overload, and that results in acute heart failure, right? Acute heart failure, congestive heart failure, right? So, if I wanted to put another sign, I could have said, what? You do the auscultation, you hear a S3 gallop, right? I didn't want to make it too easy, that's it, right? Anyway, right? So, this is a case of acute heart failure, guys. Acute heart failure. How will we manage the child? How will you approach the child, right? How will you manage? What is the first step to do? Acute heart failure. What is the first? Now, I haven't taught this, but let's discuss. Let's just talk about this. What is? Sorry?
Prop up the child.
Excellent. Prop up. Excellent. Prop up the child. First step is prop up. Prop up the child. So you raise the head of the bed. Why? This child is going into fluid overload, right? Prop up the child. Then, regarding the transfusion, now this is a very common, guys. If you go to the pediatric wards where they're doing the transfusion, you will see this a lot, right? Blood transfusions, this acute heart failure comes. What is the next step regarding the transfusion? Do you want to stop the transfusion? And what do you think? Those who want to stop the transfusion, raise your hands. What do you all think? Now, this heart failure, guys, this heart failure occurring in this child, did it occur due to an intrinsic pathology in his heart? No, right? What happened? You did some, this is what we call iatrogenic. You did some intervention from outside, and that caused the heart failure, right? So if there is no problem in his heart pathologically, here, guys, what we go for is the second step is we slow down the transfusion. We don't need to completely stop. Slow down the transfusion, right? We slow down the transfusion. No need to stop it, right? And here we have a protocol, guys, called mid-transfusion furosemide, right? That is our next third step. Put the child on mid-transfusion furosemide. What is this mid-transfusion? What is happening, guys? He's having fluid overload. What do we want? We want to get rid of the fluid. If we want to get rid of the fluid, what do we want to give? Diuretics. So specifically, furosemide is a very, one of our most potent ones, loop diuretic, right? So what do we want to give? Mid-transfusion. While the transfusion is still going on, right? You start another IV line and you give the mid-transfusion furosemide, right? You give furosemide at the same time. Okay, right? This is our initial management. Then, yes, you have to check the ABCs, right? If the saturation is dropping, you have to connect the child to the cardiac monitor. All of that is there, guys. But these three, I want you to know, right? Right? Okay, prop up, slow down the transfusion, and mid-transfusion furosemide. The next question, look at this. Read the next question. 11-year-old thalassemic child at the clinic for follow-up, while on transfusion, suddenly develops an itching rash. How would you want to proceed? What should you do first? What is this most likely? Come on.
Allergic reaction.
Most likely an allergic reaction. If during some transfusion, right? If someone is developing an allergic reaction, what is one of the first investigations we must do immediately? What do you all think? Look at this, guys. Have you all heard the word anaphylaxis? Right? You all have heard the word anaphylaxis. What is the difference between an allergic reaction and an anaphylaxis reaction? What is the difference? The primary difference, there are multiple differences. What is the main difference?
Anaphylaxis is life-threatening.
Okay, life-threatening, yes. Okay. How do you assess
Involvement of one.
Involvement of?
In plus any other organ.
Any other organ. Okay, good. We are getting nearer. How do you assess the involvement of other organs? Or how do you assess, like Tarendra said, how do you assess the severity? Or like Atib says, how do you assess the involvement of other organs? Here, guys, one of the main things you have to first do is check the blood pressure. If there is allergic reaction plus blood pressure dropping, hypotension, that is anaphylaxis. Right? If just the rash is there, that is the allergic reaction. Okay. So the first thing I want you all to do, check the blood pressure. Check the blood pressure to confirm if this is going to anaphylaxis or not. Right? If the blood pressure is dropping, this is anaphylaxis. Okay. Now, if you confirm that this is anaphylaxis, what should you do immediately here in this case?
Stop the transfusion.
In this case, stop the transfusion, right? Not like in our acute heart failure. This case, stop the transfusion, right? Stop the transfusion. And then what is our drug of choice for anaphylaxis, guys? What is our drug of choice?
IM adrenaline.
IM adrenaline. Everyone knows this, right? IM adrenaline, right? Now, Dinitha is a third year, yeah? Dinitha?
Yes.
Yes, so everyone else here is fourth year and above. Dinitha, have you all learned the dosing? Have you all?
Yes. I can't remember.
Right, it's okay. It's fine. If you all have learned, very good. Right? So everyone here else so you all also have learned. So Dinitha also has learned. So Dinitha is only third year and he also has learned. So no issue, right? What is the dose? Here, guys? IM adrenaline, how much do we give? How much should we give?
5 to 1 milligram, 1:1,000. Dilute.
1:1,000, yes. 1:1,000, correct. We give 0.1 milligram, right? 0.1 ml per kilogram. 0.1 ml per kilogram, right? 0.1 ml per kilogram. And we can repeat this up to 3 times. Up to 3 times we can repeat. Okay? Up to 3 times we can repeat. Then, guys, apart from this, we can also add, right? There are some other drugs, right? Chlorpheniramine, right? Depending on availability, right? Chlorpheniramine and hydrocortisone, right? We can add these, right? Right? If there is no response, let's say you did all of this, no response, where can we go? What can we do? Right? What should you do first? Let's say you started your housing officer period. No response. What are you going to do? Take your phone, right? Take the phone, immediately call the seniors. That's the first thing. Okay, don't go to do anything else. Call your seniors, right? Consult the seniors because we are going to go into some second line medications. For those you need senior consultation, right? There is IV adrenaline infusion, right? There is IV glucagon that we can give, normal saline drips, right? Second line medications, we need senior consultation. Up to this, you can do without any problem. Okay? You must do, right? Okay. Is that clear? Right. So that is it, guys. That is it for thalassemia, right? Can I see some faces? Let me see. Did you all understand today's content? Right? Show me your faces, huh? Anyone fainted yet? Right? No? All good. Give me a thumbs up, right? Let me see some happy thumbs. Right? Excellent. Right? Manari, all good. Manari, Mulyavitan, yeah, all good. Dilmi, right? Dilmi, Manari and Arshin, no? So 3 girls. Right. Good. Okay. So that's about it, guys, for today's session, right? I will see you guys again tomorrow, same time, 4:30. Tomorrow we are going to talk about UTIs. Again, tomorrow also, guys, tomorrow's topic. Now, both of these topics I purposely chose. These are more pediatric heavy topics, right? Thalassemia and UTIs both, right? Especially exam concern, thalassemia UTI mostly in your pediatrics, right? But tomorrow we will talk about adult onset UTI, but wherever necessary, again, I will put the necessary pediatric guidelines and protocols. Okay. So that's about it for thalassemia, guys. I hope you all understood everything. If there is any question related to the content, just drop me a message, right? We can discuss, right? Over WhatsApp, no issue, right? That's about it. I'll see you guys tomorrow, same time, 4:30, right? Take care. See you guys tomorrow.
Thank you so much.
You're welcome.